Good morning and welcome to the event. We're just going to give maybe just a few more minutes. It's about 8:02 and just going to give a few more minutes for some last people to log in, and then we will go ahead and get started in just a few. Thanks. Okay, good morning, and hopefully everybody is waking up on this snowy morning nice and warm, and very glad that Zoom exists and that we're not all driving to a meeting, and glad that we can enjoy this morning together. I'm just going to change one setting here. Okay, great. Well, welcome to the Eye Care Center of Northern Colorado Continuing Education event. Just a quick introduction. Most of you know us well. We're the Eye Care Center of Northern Colorado, made up of, we have our main office in Longmont, and that's also where our surgery center is, Advanced Vision Surgery Center. Retina team is made up of Dr. Benedict, Dr. Tilton, myself, and Dr. Manry. We have our lovely glaucoma and cataract team, two of whom we'll be hearing from this morning, Dr. Rosting, Dr. Sheff, and Dr. Parikh. Our oculoplastics and cataract team, Dr. Myers, who we'll be hearing from this morning, and then also our cornea and cataract team, Dr. Werner. And then our primary and comprehensive eye care team, we have Dr. Crone, who does complex contact lens fitting and care, Dr. Wolford, ocular surface disease, and our newest addition to the team, Dr. Melissa Burton. We're very excited to have her with us this year, and she takes care of all general ocular disease. We have our Advanced Vision Surgery Center, which is dedicated to the state-of-the-art ocular surgery, exclusively does ophthalmology surgery, and located near our main office in Longmont. And just a quick reminder, we have 4 different locations to serve you and your patients: main office in Longmont, our office in Boulder, our office in Lafayette, and then our office in Greeley. So we'll get right into the first presentation, which is by myself. It's going to be ocular toxicity of systemic drugs. So let's see if we can successfully switch here. All right. That did not switch. Okay, great. It wouldn't be a Zoom meeting if there wasn't a couple technical errors. Great. So we're going to get right into ocular toxicity of systemic drugs. I'm Justin Canoff and do surgical and medical retina. So I'm going to try to take you, I thought this was a very interesting topic to do because we all tend to focus exclusively on the eye and, our own little niche of the body. And I think sometimes I know I'm definitely guilty of looking right at the patient's chief complaint, completely breezing through their medical history and all of the drugs they're taking and skipping right to the vision and the pressure. And I think it's really important for us to remember to stop at that section looking at systemic drugs and really understand what systemic medicines our patients are taking, because very commonly those medicines can affect the eye and affect what we're seeing. So I was going to try to take us through the eye, sort of moving from the front of the eye to the back of the eye and just sort of go over some of the, it's a mix of going to be common drugs that can cause toxicity and then some less common ones that can cause very severe toxicity, and try to sort of remember those two categories. And there's going to be a whole bunch of drugs in between that are less common that cause very rare toxicities. And I always try, if I'm looking at the patient and having a hard time figuring out what's going on, I always just try to stop and go back and look at what drugs they're taking. And, especially if there's a less common drug on there for cancer or different immunomodulatory drugs, I'm not shy. And, sometimes I'll say, let me look up this drug and see if this is causing your problem. Or sometimes I'll ask the patient, I'll tell them I'll call them a little later in the week and I'll have to do some research on PubMed or UpToDate, seeing if this drug is really causing their eye problems. So starting in the front, so the taxanes are drugs that we are not particularly familiar with, and they're used in chemotherapy. So doxytaxel and paclitaxel, they are chemotherapy drugs used in the treatment of breast cancer, head and neck cancer, stomach cancer, prostate cancer, and lung cancer. And they're typically given through an IV infusion every 1 to 3 weeks. And this is one of those drugs that was actually found and discovered from one of the natural plants from the yew tree. It's a picture of a yew tree. Never heard of a yew tree, so I had to look it up myself. And what it does is it interferes with microtubule assembly. And if we all harken back to our college biology days, basically, while cells are dividing, they have to segregate the DNA and the chromosomes into the two different halves of the cell, and then that cell will divide and then form two new cells. And these microtubules are involved in how the chromosomes are able to align and then track to one side or the other during mitosis. And so these drugs inhibit those microtubules, which then inhibits cell division, which then inhibits the growth of cancer cells. And so basically these taxanes are secreted into the tears. And what happens is as it's secreted into the tears, it results in stenosis of the punctum and the lacrimal drainage system. And it's very common. It can cause epiphora in up to 80% of patients on these medications. And the treatment is really, with any of these drugs, it's really going to be a balance between, do you stop the drug or do you sort of live with the drug side effects and try to treat them? And it's always going to be that risk benefit that we have to take into account between the patient's eyes and between what's happening in the rest of their body. And so in this, there's a clear risk benefit. Well, on one hand, these drugs are helping to keep the patient alive versus they're causing some tearing. So obviously we're not going to ask the oncologist to stop the life-saving drugs. So we can treat it with either topical steroids, or if it results in severe stenosis, we're involved in surgical stenting, or maybe even needing a DCR or a Jones tube. So next class of drugs are the bisphosphonates. And so these are very, very common drugs that are used to treat osteoporosis. And I think now I've seen sort of a little more care on some of the primary care doctors and some of the endocrinologists. A few years ago, it seemed like everybody over a certain age was on one of these drugs to help with osteoporosis. But I think there's been some more recent research that it can really sort of change a little bit of metabolism and some of the metabolic homeostasis. And so a little more careful with them. They come in both oral and IV. So for example, Fosamax is an oral drug versus Reclast is a IV infusion. And again, a lot of this lecture is going to be really reaching back into biology that we all took many, many years ago. So these medicines are inhibiting the osteoclasts, which are the cells that break bone down, which allows the osteoblasts, which build bone, to work better. And therefore, when you change that balance between breakdown and building, and you sort of push it towards the building, you can help to increase bone mass and bone density. So these drugs can cause a number of different ocular side effects. It can cause a conjunctivitis, an episcleritis. It can cause an iritis, keratitis, scleritis. So commonly, you're going to see it about 2 to 3 days after one of the IV infusions, or it's going to start about 6 to 8 weeks after one of the oral medications are start. And again, it's what we're going to talk about many times. It's the risk benefit of the side effect versus the drug. And so one thing would be to suggest the endocrinologist maybe switching to a different drug of the same class, switching from an IV to maybe an oral medicine, or from a different oral medicine to another one. And then depending on the severity, it might be necessary to discontinue it. All depends on how severe the side effect is versus how severe the osteoporosis is and how much they need this drug. Okay, so we're going to do our first poll here. All right, so let's see if we can get this poll to come up. So we want to try to make this interactive, which I think is one of maybe the fun things on Zoom, is that we can do this. So we're going to try launching this poll here. Okay, great. All right, so if everybody just takes a quick second to vote here. So what is the most common ocular effect of amiodarone? Is it dry eyes, vortex keratopathy, a pigmentary glaucoma, or a pigmentary retinopathy? All right, so we'll just give a few minutes here. I guess actually a few seconds, not a few minutes. Okay, so let's share the results with everybody here. There we go. All right, so the definite vote is the vortex keratopathy. All right, so let's go back. Okay, so amiodarone is a common drug that we're going to see our patients on. It's used to treat cardiac arrhythmias. Very common, over 2 million prescriptions per year in the United States. And it blocks the voltage-gated potassium and calcium channels in the heart, which is going to help treat arrhythmias and affect the repolarization phase of the cardiac cycle. And as everybody very accurately remembered, the most common ocular effect is the vortex keratopathy, or the corneal verticulata, as we see in this photo here, where you get these sort of whirl effects on the cornea. So it's very, very common in patients with amiodarone. It's going to be present in the majority of patients, but luckily for this particular drug, it's very rarely visually significant, and a lot of times something interesting for us to see, and sort of a little party trick we can use with our patients, where you can ask them if they're on amiodarone, and then they say, "Wow, that's a great guess," and then you sort of can impress your patients. So very rarely visually significant, but sometimes they can get halos or light sensitivity. And so for the vast majority of patients, even if they have these sort of relatively prominent findings on the cornea, if the patient is asymptomatic and not having trouble, then something we just watch. And if they are starting to have trouble with it, then most of the time when you stop the medicine, it'll resolve within months. But again, this is very rarely necessary, and something I would definitely discuss with the cardiologist rather than telling a patient to stop this medicine. And that's really the common theme I approach. Even for example, when I see a patient who comes in with very clear Plaquenil toxicity, slam dunk Plaquenil toxicity, I still don't tell the patient to stop the medicine. I say, this is what we're seeing. I'm going to reach out and talk to your doctor. Let's then work together as a team to talk about stopping the systemic medicine. So very rarely will I stop a systemic medicine without involving the prescriber. It's exacerbated by contact lens wear. So that might be something to double check in a patient who's having contact lens intolerance or difficulty with their contact lenses. And we'll get to this again a little later, but rarely it can cause an optic neuropathy, which on the other hand, different from the corneal reticulata, would be a reason to stop the amiodarone. So that's just something to keep in the back of your mind. Okay, so amantadine is a medicine we don't see used as much anymore. It's still used in the treatment of Parkinson's disease, can be used in some of the treatment of dementia or some other neurological disorders. And it used to be very commonly used in the treatment of influenza A. The treatment with influenza really started in the 70s and 80s before we have our more modern antiviral medicines that are used for influenza. And after it was, and just like any antibiotic or antimicrobial, as the use of amantadine increased in the 70s and 80s, it actually pushed towards a selection of flu viruses that were actually immune to it or resistant to it. And so it's very rarely now used for influenza, but still used for Parkinson's disease. And you can get this association with very severe corneal edema and an endothelial toxicity. And can see that in about 0.2, 0.3% of patients over a 2-year treatment. And this would be something where you would want to stop, have the primary care doctor stop the medication. So you can get this very severe corneal stromal edema that usually is reversible if it's caught quickly and the drug is stopped. But if the drug is continued, it can result in permanent endothelial dysfunction. So this would definitely be something that you would want to stop and work to change to a different medicine. Okay. So we definitely invite questions. So I can see I have the chat window open on a second computer here. So if anybody has any questions that they sort of want answered, just go ahead and put a question into the chat panel, and I'll be able to answer that in real time, or we can sort of answer questions at the end. Okay, so moving on to a different section of the eye. So talking about angle closure glaucoma. So angle closure glaucoma, I think, is actually one of the more common and certainly more severe drug toxicities we can see. There is a number of systemic drugs that can cause secondary angle closure glaucoma. So all of these drugs work by a common mechanism. Essentially what happens is these drugs cause a choroidal effusion or a ciliary body effusion. And essentially what happens as that posterior pressure develops from the choroidal effusion, it pushes on the ciliary body, rotates the whole lens forward, the whole ciliary body lens complex forward, closes the angle, and then results in that secondary angle closure glaucoma. And we can see that here on this UBM. So just to orient everybody, this is the front part of the eye here with the cornea and the anterior chamber right here. This is the back part of the eye. This is the sclera, and then this is the sort of ciliary body and choroid, and then this is the suprachoroidal space. And so this large black space here is something that shouldn't be there on a UBM. So this is a choroidal effusion, which is then causing a secondary push forward. And then here's the angle right here, which is completely closed because of this posterior pressure. And so common medicines that we've seen from, I would say probably one of the most common one that I have seen cause this is topiramate or Topamax, which can be used as an anti-seizure medicine or can also be used as migraine prophylaxis. And so I think this is the most common medicine I've seen cause this. Venlafaxine and fluvoxamine are both antidepressants. Fluvoxamine is brand name is Luvox, and venlafaxine is Effexor. So carbonic anhydrase inhibitors or any type of sulfa drug. I think this is actually the most recent patient we've seen come into the office. We had a patient who was traveling. I can't remember where they were traveling from, but they came up to Colorado for a ski trip, and they were trying to avoid altitude sickness. And so their primary care doctor had given them Diamox. And I think they took only 1 or 2 doses of the Diamox as they came up here, and they developed a bilateral secondary angle closure glaucoma from the Diamox. And then bupropion is Wellbutrin. So this is one of those instances where I would actually suggest stopping the drug rather than waiting for the primary care doctor. Have to be careful, especially with these antidepressants. A lot of times they need to be tapered. Because depending on the half-life of these drugs, sometimes suddenly stopping these drugs can cause a serotonin withdrawal in patients. But this is one of the instances where I wouldn't want to wait 2 or 3 weeks for the primary care doctor to decide when to stop the medicine. So most of the time, just stopping the offending drug and then a combination of medical treatment. So medical treatment, I would use all of our topical medicines, although I would be careful about using sulfa drugs. And, in terms of Diamox, it's going to be that risk benefit. Obviously, if the patient is having, our patient who had the angle closure glaucoma from the Diamox, we didn't start Diamox. But in patients who have had this from Topamax, I have used Diamox if necessary. You can also treat with cycloplegic medicines, which is a little different than we typically do with angle closure glaucoma because of the mechanism here. So these dilating or cycloplegic medicines, in addition to dilating the pupil, which is not really the main effect, it's actually going to help move that ciliary body back, and that can help break the angle closure glaucoma. I have used oral steroids in these patients to help quiet down the effusions. And then an LPI can be helpful or not. It sort of depends on if there is sort of a secondary iris Bombay as well. Because again, if the main effect is just simply a mechanical pushing forward of that ciliary body and lens, doing a LPI or a laser peripheral iridotomy is not necessarily going to help that. So it's all sort of feeling out if that's needed or not. So dry eyes, I'm gonna sort of breeze over here a little bit because dry eyes is a side effect of so many medicines. Definitely the most common anterior segment side effects of drugs. Treat symptomatically, and again, it's really going to be, is it worth discontinuing the drug, for the dry eyes? And it's again, just like anything, it's a risk benefit. And one of the common mechanisms that these drugs have a dry eye effect is from a secondary anticholinergic effect. So if you think of your parasympathetic and sympathetic nervous system, the parasympathetic is involved in secreting tears. And so a lot of these, especially the antihistamines, the antihypertensives, a lot of these medicines have sort of a secondary anticholinergic side effect, which dramatically contributes to dry eyes. But for most of these patients, it's going to be treating this symptomatically and just really sort of making them aware. I think just making them aware of, hey, you're having very severe dry eyes, probably is a side effect medicine. We're going to treat it. I think just gives them a little bit of peace of mind, helps them understand maybe why they're having such dry eyes. That's not necessarily a need to stop that medicine.
Excuse me, Justin, can you check your audio? They're getting a lot of reverberation suddenly.
Well, let's see if we can fix that. Let me try switching to a different microphone here. See if that helps the feedback. Okay, is that better? How is that sounding here?
That's better now.
Okay, great. Okay. Okay, so all right, great. So going to move on to the back part of the eye. So talking about retinal toxicity. Okay, so let's go to our second question here. All right. Okay, so which route of steroid administration cannot cause central serous retinopathy? So inhaled steroids, nasal steroids, oral steroids, topical steroids, or all of these can cause CSR. All right, we'll just give a few seconds here. Okay. Great. So most folks picked CSR, and I'll get back to this poll in a second and just sort of highlight a few things. But yeah, so the right answer is any type of steroid can cause central serous. All right, so let's get back here. Okay. All right, so central serous chorioretinopathy and steroids. So any type of steroid medicine can cause central serous. And really the point of putting that poll up and sort of talking about this is that, I find when I see patients with central serous and just asking them if they take steroids is not enough. Because patients will forget they take steroids. They'll think only medicines they take by mouth counts. And a lot of times I'll ask patients 3 or 4 times, I'll look through their medications if they take any steroids, and then I'll actually go through and say, what about an inhaled steroid? What about a topical steroid? What about an injection? And then all of a sudden they'll say, well, yeah, I get these injections in my hip for my arthritis, but my doctor just told me they were pain injections. And then they'll end up being steroid injections. So it's really important to really go through all of these. And I've seen patients who actually themselves are not actually taking any of these steroids, but I've seen patients where their kids are using like a topical steroid cream for a rash, and just the parent getting the little bit of steroid cream on their fingers and rubbing it on their children's rash is enough to cause central serous. So it's really sort of, really going through that really detailed. And it's not dose dependent. You can have people getting massive doses of oral steroids who get central serous. You can have a parent who gets a little bit of steroid on their finger and get central serous. And I've actually seen this a few times complicating when I'm trying to treat a posterior uveitis. One patient in particular, I remember had a very severe retinal vasculitis. And I was trying to control his retinal vasculitis with oral prednisone as I was transitioning him to Humira. And then in the process, as his retinal vasculitis was quieting down, he then developed central serous from his oral steroids. So central serous, so it's central subretinal fluid. And especially in older folks, it's really important to differentiate this from macular degeneration, because they're obviously very different treatments, very different disease course. One we can observe and simply try to stop the offending medicine. One needs treatment. So it's going to be very key to look for blood, and the examination in the other eye is going to be extremely helpful. Is there drusen in the other eye? Is there other signs of macular degeneration in the other eye? And then it's going to be very critical to get a fluorescein angiogram and an IC green to trying to see, is this a choroidal neovascular membrane, or is this actually a leak from central serous? So this is just a characteristic appearance of central serous. So this pocket of subretinal fluid underneath the retina. And then this is a fluorescein showing a very classic appearance. So we can see on this photo here, there's a large serous retinal detachment right here with subretinal fluid. And then in the early phase, we see a small leak that then as it goes later expands and expands. And this is a very classic appearance of central serous to help differentiate it from a choroidal neovascular membrane. The other features I find very helpful, just looking at an OCT, is going to be looking at what the retina looks like. So this is, again, a very classic appearance where we look outside this serous detachment. There's no drusen, there's no pigment epithelial detachments. The subretinal fluid is very uniform. There's no blood in there or anything else, versus, seeing an OCT where it has, a lot of drusen or pigment epithelial detachments. That's going to make you think this could be a choroidal neovascular membrane. The other thing that's very helpful is the vision. So in somebody with this degree of subretinal fluid with central serous, it'd be very common for this patient to be 20/25, 20/30, and just be, sort of complaining of some anisoconia or a little bit of distortion. Whereas this patient with a subretinal fluid from a choroidal neovascular membrane is going to be 20/80, 20/100. So it's interesting, when they have subretinal fluid from central serous, their vision tends to be very good, versus when they have subretinal fluid from a choroidal neovascular membrane, their vision tends to be much more severely impaired. So the treatment is stopping steroids if you're able, and avoiding future steroids at all costs. And I have the talk with patients, again, risk benefit, and most of the time, we can stop these steroids. It's not that common for people to be on chronic steroids that they necessarily need, and that's the only option to prevent loss of limb or life. So the talk I tell patients is that if you're getting steroids for allergies or for a cold or for something, for a little minor rash, then definitely avoid steroids at all costs. If you're in the emergency room and you need steroids to save your life, then obviously you take the steroids and we deal with the eye effects later. And then I just ask them that if your doctor is going to start you on steroids, just call me and let's have a talk about it. And I can try to educate the primary or the other doctor who's starting the steroids and see if we can find an alternative. And a lot of times the patients can find an alternative to chronic steroid use. And then if I have a patient who has central serous and it keeps recurring, and I've asked them the question, multiple times, and we can't find any steroid use, then I'll actually go looking for an endogenous steroid. So sometimes patients can have an adrenal tumor or some other endogenous steroid production, which can cause central serous. And the key thing here, what I find is important, is actually ordering the correct test. Because if you order just a random blood cortisol level, those are almost impossible to interpret, because depending on how the patient's hormones are cycling, depending on the time of the day, it can be high, it can be low, it can be falsely low, it can be falsely high. So just a random cortisol level is almost meaningless on its own. So what I do is I do a 24-hour urine cortisol. And so basically patients go to the lab, they're given a big milk jug, and they basically collect their urine for an entire 24 hours. And then the lab tests the steroid level in that urine. And then that gives a much more reliable look at what their sort of endogenous steroid production is. So in terms of treatment, so one is stopping the medicine or just watching, or we can try focal laser or photodynamic therapy. In terms of medicines, there was a big sort of trend maybe 5-6 years ago of trying these medicines, rifampin or eplerenone. And I've honestly just been very unimpressed with them. I don't particularly think they work well. They've only been tried in very small trials, and there's never been a real randomized study, which is always, you always have to question the benefit. And so my go-to treatment is photodynamic therapy, because I think it works amazingly well. We use what's called a half fluence, so there's almost zero risk of any type of retinal damage, and it has a very durable effect. So I've actually been using PDT earlier and earlier because it works so well, and there's really no lingering effects for the patient. And I think as we see these drugs and as we get better imaging, I think we're really appreciating that central serous is not as benign as it was. I think 20 years ago, before there was OCT or really good multimodal retinal imaging, the thought was you got central serous, it went away, and it didn't really cause any retinal damage. And if it came back, that it just sort of didn't really cause damage. But now we see these patients who get these chronic or these multifocal events, even from the first event, it can start to cause damage to the photoreceptors. And so my sort of philosophy has changed a little bit because we have a treatment that works great, has almost no side effects. And so why wait for photoreceptor damage to happen? Okay, so question number 3. Let me launch this poll here. Okay. When a patient is taking hydroxychloroquine at a dose of less than 5 milligrams per kilogram per day, regular retinal screening is not necessary. So we'll give people a few minutes there. Okay. Okay, so this is so we got a little more controversy with this question, which is great. So we'll get to that answer in a minute. So we had about 18% of people thinking that if we're less than 5 milligrams per kilogram per day, then regular retinal screening is not necessary, and then 82% say it still is. Okay. All right, so hydroxychloroquine. So common treatment for rheumatological conditions. And according to some people, may be a possible treatment for COVID, but that obviously turned out not to be true. So even before it was being hoarded for COVID, there is it's an extremely common medicine with more than 5 million prescriptions per year. And from a rheumatological perspective, for lupus or for rheumatoid arthritis or for Sjogren's or for many of these systemic conditions, it is really a fantastic treatment because it has very low systemic side effects, very low toxicity, very well tolerated, and actually works remarkably well for patients. But it does cause, it can cause retinal toxicity. And so it's not a common side effect, but it's definitely something that we need to be aware of and something we need to screen for. So at about 5 years of therapy, you'll see it in about 1% of patients. And the longer patients are on the drug, that'll go up to, patients at 10 or 20 years, you can see it, or 5 or even 10% of patients. And so it's definitely something that is dose and time dependent. And the recommendations have changed. So the current recommendation is that patients should be taking at a dose of less than 5 milligrams per kilogram per day. And so what I do for all patients who come in for a Plaquenil screening is the first thing I ask them is how many pills are they taking a day? Because most people don't know their dose, but they know how many pills. Only comes in one dose. The pills are always 200 milligrams. So people will say they're taking 1 or 2 or hopefully not 3 pills a day. I haven't seen that in a while. Most rheumatologists know that's not a good idea anymore, but sometimes you'll see 3. So we'll ask them how much they're taking, and then I'll ask them how much they weigh. I'll just ask my iPhone to convert their, because everybody gives their weight in pounds, convert it to kilograms. So, say they're taking 400 milligrams a day, divide that by their 100 kilogram weight. And then you have that patient's taking 4 milligrams per kilogram per day, which would be a safe dose. And so patients who are less than 5, I tell them that's a good dose. For patients who are more than 5, I will then tell them, well, from my perspective, that's a little bit of a high dose from the eye standpoint. And then what I'll do is I'll say, I'm going to contact your rheumatologist, ask them if they think it would be reasonable to reduce the dosing. And then I'll ask that patient to then themselves follow up with their rheumatologist in about a few weeks. And I've never had a rheumatologist, after I sort of suggest to lower the dose, tell me that they think the patient needs to stay on the higher dose. And then every patient who I've had lower the dose, when they come back, I've never had a patient tell me that the Plaquenil has stopped working at the lower dose. So I think there's really good evidence that being below this dose is much safer for the patient, and really good evidence that this doesn't affect their systemic treatment. So important is fundus examination is not enough. And to get back to that poll, even patients who are on that dose below the 5 milligrams per kilogram per day still need screening. And so I think the most important guideline that has really changed recently is that a fundus exam is not enough and a Humphrey visual field 10-2 is not enough. Really, one of these three advanced screening modalities has to be done, whether that's a spectral domain OCT, fundus autofluorescence, or a multifocal ERG. And it's going to be very uncommon to have access to a multifocal ERG. So all of my screening is done with an OCT and fundus autofluorescence. And I think the big point, I think the key point is, especially why a 10-2 visual field is not enough, is we really don't want to be finding these patients when they're having visual field or visual trouble. Really, we want to be finding them when we can see the changes on imaging, but before it's actually affecting their function. So this is a fundus autofluorescence picture, and that we can see this classic bullseye maculopathy of this. Here you can see this increased hyperfluorescence circle around in this parafoveal zone, and that's going to be your earliest indication of toxicity. And then that corresponds here to this perifoveal thinning that we see on OCT. And at this point, in my mind, it's mandatory to stop the medicine. I don't, it's not an emergency. They're not going to get increased retinal toxicity within a few weeks. But when I see retinal toxicity, I send a letter to the rheumatologist, but I also will call the rheumatologist directly. And again, I've never had a rheumatologist say, well, they have retinal toxicity, but let's go ahead and continue the medicine, because there's a lot of other options for these patients. So the goal is to find toxicity before the patient has symptoms. What I will do is I will screen yearly for the first 5 years, and then I actually screen the patients every 6 months after that 5-year mark. Other important considerations is thinking of other things that can increase the risk of toxicity. So liver or renal disease can increase the risk of toxicity. Other retinal toxic drug can increase the risk of toxicity. And then other retinal disorders, it's not necessarily that having, for example, macular degeneration, it doesn't necessarily make it more likely that you're going to get plaquenil toxicity, although it could increase the risk a little bit. It's mainly that it's also harder to detect. So, and then when it does happen, it can be more rapid. So if I see a patient with a mild macular degeneration and they're on plaquenil, and I still feel like I can very well assess the ellipsoid zone and the outer retina, then I'm comfortable with them being on the plaquenil. But once they start having significant vision changes from the macular degeneration, or if it just advances to the point where the OCT is going to be really hard for me to find subtle changes, then I will ask for them to stop the drug. And once you stop the drug, most of the time it will not progress, but it also won't recover. So generally you want to find this before they have toxicity. Okay. All right, so going to something rarer, but something that is seen, that we're starting to see a little more common, are these so-called MEK inhibitors. So MEK is a mitogen activated protein kinase. And basically there's this really busy pathway here where you have all of these different enzymes. And essentially what this is basically showing is the path between a receptor coming onto the cell, a signaling coming onto the cell receptor, going through this whole pathway and then leading to replication and mitosis of those cells. And essentially, this is one of the common, themes of cancer is that cancer cells will get mutations in these systems that regulate cell growth. And what happens is some of these cancers can get a mutation in what's called this MEK pathway, which then allows these cells to grow and divide without any regulation. And then that leads to tumor growth and cancer. So these are some of the common MEK inhibitors. All of these are used for melanoma. And a lot of time, and actually the oncologists are very aware of drug side effects. And so all of the patients I've seen on these MEK inhibitors are specifically referred in from their oncologist to have screening for these side effects. So So the frequent side effects that can occur with these MEK inhibitors are going to be a multifocal serous detachment or pigment epithelial detachments, like you can see on these OCTs. You can also get an optic neuropathy, vein occlusion, cystoid macular edema, uveitis. Unfortunately, it's one of these ones that can cause a lot of side effects. And again, this is a classic risk benefit. You know, these are typically not first line drugs, it seems like, from oncologists. So patients who are getting these drugs are pretty sick. So, you know, really what you want to try to do is treat the side effects from these drugs. Again, it would always be worth having a conversation with the oncologist. But if these drugs are keeping a patient alive, we're not going to really want to stop them, you know, to treat, you know, their pigment epithelial detachment. So really, it's going to be treating these patients with treating the side effects and trying to get them through their treatment rather than stop the drug. Okay, so talc is an interesting drug. So usually talc is not something that's able to gain access through the bloodstream. A lot of times talc is very commonly used as a filler in oral medicines, just as something to bind medicines together. So obviously when you take it orally, the GI tract filters it out and, you know, comes out of your body, doesn't get absorbed. But when we can see this is when patients are taking oral medications and crushing them and then injecting them into the bloodstream. So for example, methadone or oxycodone or OxyContin or some of these other long-acting pain relievers, patients will then take those instead of taking them orally and getting the long-acting pain effect. If you crush it, dissolve it, and then inject it, you can then get a very quick high from it rather than the long-acting effect. And basically, then you're essentially introducing talc into your bloodstream, which is not ideal. And a lot of time, the large particles will be filtered out by the lungs, which is as bad as it sounds, but that keeps it, because if they're injecting it into their venous system, in order for it to get to the eye, it would have to pass through the lungs, access the arterial system, and then go to the eye. And so typically the lungs are filtering this, but over time, shunts can develop that allow these large particles to bypass the lungs and then can get stuck in the eye or anywhere else in the body, or small particles can go through. And you can get anything from a classic small crystalline retinopathy, where you literally just see talc particles stuck inside the small retinal arterioles. And here, this is just going to be something to recognize and ask the patient. And this is going to be a really hard one to get the patient to admit necessarily, because this is not going to be on their medication list. You know, it's going to be, typically they're not going to say, yeah, I take methadone and crush it up and inject it. So it's really going to be asking the patient and seeing if they're using any systemic IV illicit drugs. And then chronically, it can lead to non-perfusion and essentially developing severe neovascularization as the blood vessels get blocked up, almost like a diabetic retinopathy, and then leading to new vessel development. So this is going to be one where you really have to have a high suspicion to diagnose it. Other crystalline retinopathies, tamoxifen is not used as much as it previously was for the treatment of breast cancer, but definitely something to be aware of. And then these nitrofurantoin is a medicine used to treat urinary tract infections. And then these two in the middle is really something that's only I've seen asked on boards and sort of just a classic thing you see in textbooks, but not used anymore. Canthaxanthine was a oral medicine that was used as a sort of artificial tanning product a long time ago. And then methoxyflurane is a inhaled anesthetic gas, which is also not used anymore. So this is something sort of new, hot off the presses in the last year or two. And something really that's a completely new entity that none of us knew had heard of before. So Elmiron is pentosan polysulfate, which is actually, it's not an uncommon drug to see prescribed now that I've become aware of it and know to look for it. And it's used in the treatment of interstitial keratitis, which is inflammation of the bladder. And it's basically thought to provide a protective coating to the wall of the bladder. And recently it's been recognized that this can cause either a mild, moderate, or severe pigmentary retinopathy. And basically, this is sort of becoming essentially like Plaquenil, where in the sense that we recognize that this is a common medicine that's used and can commonly cause a side effect. It's a medicine that tends to work well and not have very many systemic side effects, but if not known about, can cause severe vision damage. So it's a classic medicine that really needs to be screened for. And at this point, guidelines are still coming out, and it's really just trying to educate the urologists, who are most of the time the ones prescribing this, about the potential side effect. And I was actually on the drug manufacturer's website as I was making this presentation, and the very first warning on the FDA packaging now is that this can cause retinal damage. So it's on the FDA packaging, and so hopefully urologists are now aware of it. We've still seen lots of patients who have not been told that they need to be screened for this, and so this is really something to look for when patients are coming into your office and you're seeing sort of retinal pigmentary changes that are not really clear. And one of the things, and again, we're still trying to figure this out, we as in the retinal community. Because it seems like that, unlike Plaquenil, that this actually can continue to progress after stopping treatment. But again, this entity has really been recognized in the last year or two, so long-term studies are really still needed. And it can sort of cause what looks like a pattern dystrophy. So on a fundus autofluorescence, this sort of speckled pattern of hyperreflective and poorly reflective areas. And you can see these sort of pigmentary changes in the retina, and then these sort of corresponding outer retinal changes. And, this is something that I would look at a patient and call this a pattern dystrophy if I didn't know they were on this medicine, or really until we learned about this association. And, it's another really good place to look for this is going to be for younger patients who come in looking like they have age-related macular degeneration. And, you always want to be very careful about diagnosing a patient who's 40 with age-related macular degeneration, because a lot of times it can be a masquerader. Vancomycin, this sort of came into, vernacular and scared everybody, and now it's sort of basically disappeared as people have stopped using it. So, a few years ago, there was a very large uptick in the use of intracameral vancomycin for prophylaxis after cataract surgery. And then we started seeing these very severe cases of hemorrhagic occlusive retinal vasculitis, and seems to be a type 3 immune reaction where basically the body was developing essentially antibodies and then immune complexes against the vancomycin molecule, and then causing this just massive retinal vasculitis. And essentially a lot of patients were going blind from this. And what was really scary is that because this is a type 3 reaction, it's delayed onset. So it's not like a type 1 reaction where basically, you're out in the air, you're exposed to an allergen, histamine's released, and then immediately you get the effect. This can take days or sometimes weeks to present. And so what's happening is patients were getting their first eye done with cataract surgery. They were then having their second eye done with cataract surgery a week later, and then they were developing this in both eyes. And so it was very, very scary. It can range from mild to moderate inflammation to basically just massive retinal vasculitis and occlusion. And so basically the treatment is really avoidance, because after this happens, there's not great treatment for it. We can do our best, but really at this point, the use of intracameral vancomycin for cataract prophylaxis has almost disappeared. So we have not seen one of these cases in a while. And so typically now it's either cefuroxime or moxifloxacin, which is being used. And the really interesting thing about this entity, and for which I've never really been able to find a great explanation, is that we've been using intravitreal vancomycin to treat endophthalmitis for 40 years. And this entity was never seen until the treatment was started for cataract surgery. And it's just really hard to know. I mean, one, it's just, there's just not as much endophthalmitis treated every year as cataracts is one possibility. Second possibility is that endophthalmitis can cause horrendous changes to the eye as well. So it's possible some people were getting this hemorrhagic occlusive retinal vasculitis from the intravitreal vancomycin, but it was simply blamed on the fact that the patient had a severe endophthalmitis. So for whatever reason, it wasn't really recognized, and it has not changed our treatment for endophthalmitis. If somebody has endophthalmitis, they get intravitreal vancomycin. And again, it's all risk versus benefit. But in terms of cataract prophylaxis, there's very good other treatments to use. So I'm sort of coming up at the end of my talk. So I'm going to move on. I'm sort of going to go through these real quickly and just move on to one or two last things at the end. So niacin, which some people take as vitamins, can cause CME. Again, this is a drug that you're probably going to be referred for screening. The neurologists who use this galenia for multiple sclerosis are very good at sending patients in for screening. So just in terms of optic neuropathies, just sort of mention a few. So the one to focus on is ethambutol, because this is still seen. So ethambutol is a medicine used for the treatment of tuberculosis. But in addition to tuberculosis, it's also used for the treatment of other mycobacterium. And so besides tuberculosis, there's a number of other mycobacterium that can affect patients. Most commonly patients who are immunosuppressed for a variety of reasons. Very common in the era of HIV before our current highly effective therapies. And then just on patients who have chronic immune suppressants for either inflammation or other rheumatological conditions, they can get lung infections or GI infections with these mycobacterium. And ethambutol is one of the treatments that's used as part of a 4-drug regimen. And it can cause a very well-documented optic neuropathy. And it's due to a direct toxic effect on the retinal ganglion cells. And essentially what it's doing is it's stealing the copper and the zinc that the mitochondria needs to produce energy. And those cells are very, very susceptible to this and can see a toxicity rate of about 1.5%. And really one of the earliest signs is a dyschromatopsia. So really screening these patients with color plates is actually a very sensitive and reasonable screening. And the patients I've seen get in trouble are basically when their infectious disease doctor wasn't screening them with color plates. And unfortunately, I had my most recent case is I had a patient who their infectious disease doctor was actually doing the right thing and screening them with color plates. But what was happening is I suspect it was one of the techs or the medical assistants who was doing the screening, is they were showing the patients the color plates with both eyes open instead of one eye individually. And then when this patient came in and we did the color plates in each eye individually, one eye was normal and one eye, the patient had a severe dyschromatopsia and optic neuropathy. But luckily, after we stopped the ethambutol and the infectious disease doctor switched to a different medicine, her optic neuropathy actually dramatically improved. So just real briefly, amiodarone can also cause an optic neuropathy as well. So something to think about. It can masquerade as an ischemic optic neuropathy. Okay, well, thanks for your attention. Sorry for the audio difficulties in between, but hopefully that was interesting. I'll take a quick second to see if there's any questions, but then if not, we will take just maybe a 2 or 3 minute pause, and then we'll switch on to the next presenter. And during the pause, I'm going to put the QR code up on the screen for everybody to get their credit for this lecture. So let me.
Okay. Sorry, give me a second. I'm gonna restart something here. Okay, so I'm gonna be giving kind of along the themes of medications that Justin started here, an update on glaucoma therapies. And my goal first is to review the classes of medications that we most commonly use, even though there are new things out there. You know, the vast majority of us are still using medications that have been around for a long time. And while I would guess most of you, know all the basic kind of side effects and things, I will try to throw out some things that are unusual and just maybe some pearls I've learned along the way of treating a lot of glaucoma patients. I'm going to talk briefly about newer glaucoma therapies and then just briefly provide an update on therapies that are currently in development. And so we all know that medically, if we want to reduce IOP, our options are to reduce production, which are basically agents that are going to target the ciliary body, or increase outflow. And from a medication standpoint, if you're going to reduce production, you're looking at beta blockers, alpha-2 agonists, carbonic anhydrase inhibitors, and increasing outflow, you're looking at cholinergics, which I won't talk about too much because just clinically we don't use them that much, but just listed there, prostaglandin analogs, and then Rho kinase inhibitors and nitric oxide donators. And so I'm going to just put up a couple of questions here in the beginning. We're just going to go through all the questions, and then throughout the presentation, I'll answer the questions, and we'll see how much, I don't know how difficult these questions are, but we'll see how people do. So Justin, can you put up poll 1 for me?
Yep, so the first poll is up now.
Okay.
All right, we'll give folks just a few more seconds. Okay, let's share that. All right, so, can you see these results, Monse?
I can see them. So it looks
Okay.
like most people have picked beta blocker. All right, can you put up question 2?
Okay. All right, so a patient with Fuchs dystrophy develops worsening corneal edema after starting a new glaucoma drop. Which medication class is the likely culprit? Prostaglandin analog, beta blocker, alpha adrenergic agonist, carbonic anhydrase inhibitor, or a Rho kinase inhibitor? And Dr. Preek is going to have to teach us all what a Rho kinase inhibitor is. All right, so we'll give just a few more seconds. Okay. Got a little more of a spread there. So it looks like 44% with prostaglandin and 44% with carbonic anhydrase. And then Dr. Rosti must have been the only one that clicked on Rho kinase.
Okay, we'll go on to question 3.
Question 3. Okay. Okay, question 3. Which class of glaucoma medications can cause a glaucomatous uveitis? Oh, I guess these are all
granulomatous.
Can cause a granulomatous uveitis.
All the classes are the same on all the questions, so yeah.
But I like saying Rho kinase inhibitor. Though.
Yeah.
Okay, great. So we're getting some good responses. We'll just give it a few more seconds. Okay. So looks like prostaglandin was the winner here.
Okay, and then I am going to just show a picture. And then basically the question is what medication is causing this appearance in this patient.
And if you want at some point later in your talk, I can re-show the results if you want me to. So.
Okay, I'll let you know.
Oh, sorry. Okay, so we're on poll question 4.
Yeah, we can just put the poll up. It's just to pick the class of medication.
Okay, here we go. All right, so what medication class is responsible for the findings shown? Getting a good distribution here. All right, we'll just give it a few more seconds. Okay, so looks like prostaglandin was the winner here as well.
Okay. All right. And then this is question 5, again, asking what class of medications can cause this appearance.
Okay. All right, we'll just give a few more seconds, getting some good voting. Okay. So here we got a different result. So carbonic anhydrase inhibitor was the favorite.
Okay. All right. I'm going to skip poll question 6 because Justin covered it pretty well. In his talk, I was asking a question about what type of medication can cause choroidal effusions. So, like I said, I'm going to just start with our most commonly used glaucoma classes, and then we'll talk about some of the other ones. And really briefly, I'll talk about the things that I'm sure most people already know. But I'm going to talk about beta blockers first, because these tend to have the most potential systemic side effects of all the medications that we use. We probably all know that beta receptors are found mostly in the heart and in the lungs. In the heart, there are beta 1 receptors, and basically beta 1 receptors in the heart can cause increased contraction and an increased heart rate. And then beta 2 receptors are found in the lungs, and beta 2 receptors cause bronchodilation. So commonly used medications that are agonists, adrenergic agonists that take advantage of this would be medications like epinephrine, which would cause, like a tachycardia, bring up the heart rate. And with the lungs, the most commonly, known thing that we all see all the time in our patients are patients on albuterol inhalers. So albuterol is a beta agonist, causes bronchodilation. And beta 2 receptors are also found in the ciliary body, and beta blockers topically take advantage of that to reduce intraocular pressure. So topically, we have non-selective beta blockers, and we have beta 1 selective beta blockers. And the non-selective ones are the ones that we use most of the time. So timolol is going to be the most commonly used beta blocker, and it can have cardiac and lung effects. There is a beta 1 selective medication, betaxolol. And in theory, that is something that should be safer in patients who have any type of asthma, pulmonary disease, a reactive airway disease. And because it's beta 1 selective, it has more cardiac side effects than pulmonary side effects. However, betaxolol is less effective than the non-selective beta blockers at lowering eye pressure. And the most common cardiovascular side effects that we're going to see are bradycardia, hypotension, syncope, and as everybody mostly got on the poll, exercise intolerance. And exercise intolerance basically related to the inability of the heart rate to ramp up as quickly as it would with activity. And pulmonary side effects would be bronchospasm, decreased expiratory volume. And really, there are a lot of case reports out there of patients with asthma receiving beta blockers, even, rare side effects of patients getting 1 dose of a beta blocker and developing severe respiratory distress from that. I can say for sure in my practice, I have seen patients be put on timolol and come to see me, and they're audibly wheezing in the exam room. And you can tell that, this is likely related to the timolol that was started. And so that's a very real thing. The other thing I've seen and heard a lot about, and it's something you want to ask patients about, is bradycardia from this. Bradycardia can be so bad as to cause other physicians that are involved in the patient's care to consider pacemakers. Certainly for any patient who has any history of heart block or bradycardia, beta blockers are not great options. I have had patients pass out after taking timolol. Patients end up in the emergency room. They don't put together that the topical drops can cause some of these issues. And so I typically will warn patients when I put them on these medications that there are these potential side effects. And if you start to feel anything like this, please stop the eye drop and let me know. The really less common side effects that you can see with beta blockers are hair loss. I have had several patients have this happen, but it's a very exceedingly tiny fraction of patients. There are well-documented cases of alopecia hair loss related to beta blockers and timolol. And you can have a change in lipid profile. And in theory, you can have masked hypoglycemia, also masked thyroid storm. These things, again, related to typical response in these situations would be an elevated heart rate and the beta blocker suppressing the ability for the heart rate to go up. So absolutely, I try to avoid beta blockers in any patients with real asthma. I might consider it in patients who have something like a seasonal allergic asthma, but any patient who's on a daily maintenance treatment for asthma, I would avoid a beta blocker. In older patients, I will ask them if they have any issues with low blood pressure or slow heart rate at baseline. And of course, checking heart rate in the office is a great thing to do to check a pulse before starting a topical beta blocker, because absolutely those patients are prone to developing problems with topical beta blockers. Colorado is full of young, active people and people who exercise a lot here, and definitely beta blockers can cause an exercise intolerance. I try to avoid timolol as a first-line treatment for really active patients. So I will often ask people, slightly biased, I probably tend to ask younger patients these questions more often than older patients, but I will ask them if they are runners or triathletes or, really just active people where this timolol could create an issue for them. If I put an older patient on timolol, when they come back for a follow-up, I'm always going to ask them if they feel tired, dizzy, if they've had any issues with that. And of course, don't forget that we have combination drops out there that contain timolol. COSOPT, of course, now that it's generic, most people will be using the generic. It's easier to remember. You see dorzolamide timolol, but Combigan also has timolol in it. So just back of your mind, remember that that's there. So switching over to carbonic anhydrase inhibitors. Carbonic anhydrase is an enzyme that's found in multiple places in the body. And besides being found in red blood cells, which is involved in basically breathing off carbon dioxide through respiration, it's also found in renal tubules, it's found in the ciliary body, and it's found also on the corneal endothelium, involved in the pump mechanism of the corneal endothelium. So carbonic anhydrase inhibitors, we typically are going to be using the topical ones. You have dorzolamide, brinzolamide, and then combinations, dorzolamide timolol, and then brinzolamide brimonidine or Simbrinza. And between the two medications, there is a pH difference between the two medications. And for that reason, dorzolamide tends to sting more when patients instill it compared to brinzolamide, which when it was developed was, really advertised as a less sting type of formulation. Dorzolamide also, both of these medications tend to be a little bit thick. And so sometimes patients will complain of blurring when they instill the medication. Orally, the most common medications we're going to use are acetazolamide and methazolamide. Once in a while, you're going to see patients who are on these medications as maintenance treatment, but often because of the side effect profile of the oral carbonic anhydrase inhibitors, these are not used for maintenance. They may be used temporarily to deal with very high pressure situations or to try to hold over a patient until they're going to have a surgical intervention.
Dr.
So
Priest,
top,
can I interrupt
yes.
for 1 sec? So we have
Sure.
so we have a question.
Good.
So one question was, what's the success of punctal occlusion in reducing the beta blocker side effects? And is that a good way to go about still using a beta blocker?
So, when you do punctal occlusion, most of the studies are going to tell you that you're going to have about a 60% reduction of absorption. I personally don't think it's a great way of preventing side effects, patients are not good at doing punctal occlusion correctly. So you can show them how to do it. They often don't occlude in the right place. I actually tell patients to just close their eye for a minute or two after drop instillation to reduce the pumping effect of the medications through the lacrimal system, because I think punctal occlusion is often just poorly done. I don't think that it really prevents these side effects. So that's a personal bias. I would try to avoid them if I absolutely, and it depends on the side effect profile. I mean, if you're worried about something as severe as a bradycardia that could, lead to significant cardiac issues, I wouldn't use punctal occlusion. But for example, right now I'm talking about CAIs, and sometimes people will get a bitter taste in their throat from a topical CAI. And sometimes I'll tell patients that you can try to close your eyes and occlude your punctum to try to reduce that, because that's a pretty minor side effect anyway. Was there another question?
Nope, that was the only question.
Okay. So carbonic anhydrase inhibitors topically, I already mentioned that they typically sting because they're more acidic. They have a lower pH. The blurry vision from just the thickness from the actual medication also can definitely cause a punctate keratopathy. They can get a periocular dermatitis, and this dermatitis is often a very kind of scaly looking dermatitis. So this appearance of the skin where it's shiny and wrinkled and scaly is definitely something that looks more like a carbonic anhydrase inhibitor than some other medications. Again, patients can get a bitter taste from drainage into their throat, and sometimes they will complain that their sinuses feel a little stuffy or irritated on this medication, again, from drainage. So with this particular medication, I will tell people to close their eyes to try to reduce that drainage and reduce these side effects. And then the other thing that was one of the questions that was in the poll was that carbonic anhydrase is found on the corneal endothelium, and it is involved in the pumping of the corneal endothelium. And in general, it just helps kind of ion flow and how fluid moves from the corneal stroma into the anterior chamber. And so in patients that have already impaired endothelial function, the addition of a topical carbonic anhydrase inhibitor can worsen corneal edema. I have seen this in patients with Fuchs dystrophy, pseudophakic bullous keratopathy. It would be something that I would try to avoid if you can tell that the endothelium looks abnormal, and definitely if a patient has any type of mild corneal edema. And just to remember, Justin mentioned this in his talk as well, but carbonic anhydrase inhibitors are sulfa derivatives, and there are some idiosyncratic terrible reactions that can happen from sulfa drugs, of which I've listed Stevens-Johnson and aplastic anemia. It is possible with more common with an oral carbonic anhydrase inhibitor, but just something to know about. And then ciliocoroidal effusion. So similar to topiramate, you can get ciliocoroidal effusions, which induce myopia and can potentially cause angle closure. This can actually happen with topicals too. I've seen 2 patients where I've put them on topical medications and they develop an effusion within 2 days of starting their topical medication. Stop it, it goes away, you re-challenge them, comes back. Quite rare, but it is something that can happen. So something to keep in the back of your mind. And then I just throwing this out because I think this comes up a lot, this question of a sulfa allergy and using these medications. And I was taught a certain way. I did my fellowship in Iowa, and there was a study done out of Iowa about this. And so they feel very strongly about this in Iowa. But there are some other studies that show that, sulfa allergies for vast majority of patients are related to a sulfa antibiotic. If you ask them about it, they've taken an antibiotic, they've developed a rash, and sulfa sensitivities to antibiotics are related to a ring and an amine group on the ring. And non-antibiotic sulfa medications do not have that part of the drug in them. So Acetazolamide does not contain these. And, other common sulfa medications are blood pressure medications like HCTZ and furosemide or Lasix. None of these have that entity in them. And so actually cross-reactivity of sulfa antibiotics and non-antibiotic sulfa medications is quite low. This is the study that was out of Iowa. They were mostly looking at patients who had idiopathic intracranial hypertension that they were treating with acetazolamide or furosemide. And they had patients, this is a small group, 34 patients who had a self-reported sulfa allergy that were all treated with these medications, and really nobody had any serious side effects. There was a huge study out of, I believe, England in 2003. They had 20,000 patients looking at sulfa allergies using non-antibiotic sulfas, and less than 10% of them had problems. So from a standpoint of a sulfa allergy, when a patient comes in and tells me they have a sulfa allergy, if it's known to be an antibiotic allergy, I tell them that the chance that they're going to have a problem with the dorzolamide or brinzolamide is exceedingly low. I will use these drugs routinely in patients with sulfa allergy. I will also use acetazolamide if I have to in someone with an antibiotic allergy. Of course, if they tell me it was a terrible life-threatening reaction and not a rash, I would think differently about that and not use it. But just a run-of-the-mill usual sulfa allergy, we see that is not a contraindication to using these medications. I would avoid these medications in patients with a compromised endothelium. And I found that, the biggest issue with these medications in patients is that they don't like the stinging. So I try to tell them ahead of time, it's going to sting when you put it in. That it's not a problem. It's not causing any harm to your eye. Generally, it's not going to last beyond installation. Please don't stop the drop because of the stinging. These are great medications. They work really well. So moving on to alpha adrenergic agonists, we have, again, a non-selective and alpha-2 selective group. Typically, we're going to be using the alpha-2 selective medications. The non-selective ones really aren't used very much. Alpha-2 selective, you're going to have aproclonidine, which we rarely use in patients for treatment. We sometimes will pre-treat laser patients with this medication because of its rapid onset of action. But typically, most people are using brimonidine or some form of brimonidine, and then brimonidine, timolol, or Combigan. And the most common side effects with alpha-2 adrenergics are dry mouth, pretty common, fatigue and somnolence. This is particularly common in older patients, and in very young patients, specifically in patients under the age of 6, they can actually become unresponsive from this side effect. And so these alpha agonists are absolutely contraindicated in kids under 6 years old. But I do ask older patients about this. I've had many patients tell me that an hour after they take the drop, they have to take a nap. I've had patients tell me they've fallen asleep in their car after taking a medication. And so I ask about these things. I mean, obviously, in certain situations, that can be dangerous. So I will routinely follow up with that. And then the thing that we probably all know about is this delayed follicular conjunctivitis. And it's definitely a kind of a different presentation in this medication. Typically happens after the patient has already been on the medication for 6 months. I have seen patients be on this medication for years and develop something like this. And what's really characteristic about it is not only do you get the palpebral follicles, but you get bulbar follicles. And so putting fluorescein in the eye and looking at the bulbar conjunctiva and kind of seeing the follicular reaction there, I think that is pathognomonic if someone is on brimonidine, that this is a brimonidine allergy. They typically get itching, swelling, skin fissuring that's getting worse. And while I think that it's a commonly known side effect, I often will see patients coming in with, trying to be treated with allergy medications and anti-inflammatories and things like that. And they're left on the brimonidine. And if I have a glaucoma patient who comes in with a red eye, who's on multiple medications and brimonidine is one of them, it's brimonidine until it's proven otherwise. This is the most common medication to cause this problem. I have also, this is just personal experience. I don't know that there's a study out there, but I have seen that patients who develop a brimonidine allergy like this and they're kept on the medication and the allergy gets worse and worse, and some of them that their IOP actually goes up And when I take them off this medication, they actually can settle down and their IOP goes down. I think sometimes there is a fear that stopping this medication is going to make their pressure go out of control. And I've actually seen the opposite many times. I recently had a patient on Combigan who developed this type of allergy, and they had been on it for a year. Their referring doctor was really worried about taking them off this medication. She had just a terrible skin reaction. She had an ectropion. Her eye from across the room, you could tell she had a brimonidine allergy. And I took her off the Combigan and replaced it with Timolol, and her pressure came down 8 points. So just, you don't want this allergy to build up. If you're seeing it, you should take the patient off it. If the pressure goes up, of course, you have other ways to deal with it, or you can always refer patients over to us if that becomes an issue. But certainly the tissue really can develop chronic changes if this allergy continues to fester. So brimonidine is a medication that can cause a granulomatous uveitis. That was one of the questions up there. Not a common side effect, but I have seen it. I have put people on brimonidine and come back within 2 to 3 weeks with a bilateral granulomatous uveitis. They typically also have some redness of the eye. Again, so the granulomatous part is the part that sets it apart a little bit from prostaglandin. So I think prostaglandin was the most commonly picked medication in the poll, and that typically causes a non-granulomatous uveitis if it causes uveitis. So it's quite a dramatic presentation when you see it, and if you stop the medication, it will go away. There are some case reports also of some kind of symblepharon formation with brimonidine that required the medication to be stopped and then treated with cyclosporin. So those are the less common side effects. So again, we talked about don't use it in young kids, ask older patients if they are getting really sleepy. And if you see a person who has a Combigan allergy, just always remember you can still put them on Timolol because almost 100% of the time the issue is going to be the brimonidine. So lastly, the common glaucoma medications are the prostaglandin analogs. We have our usual latanoprost, travoprost, bimatoprost, and then tafloprost is Zioptan, which is a preservative-free formulation. And these medications typically really have local side effects, which is good in a way, but also the local side effects can be quite visible to patients cosmetically. So things that we pretty much mostly all know about is you can get some hyperemia, hypertrichosis, so both longer eyelashes, thicker eyelashes, sometimes trichiasis from lashes curling in different directions. You can get iris darkening, which is irreversible if it happens. It is exceedingly uncommon in patients with a slate blue eye. People with brown eyes typically don't notice it too much. Where you're going to run into problems is usually with the hazel eyes, green eyes mixed with brown flecks. Those are the patients where the color can change. It's very noticeable to them. They're more prone to that issue. You can get periocular hyperpigmentation. You can get cystoid macular edema, more common in patients who are pseudophakic or have had cataract surgery. You can get a non-granulomatous uveitis. There's a concern about recurrence of HSV keratitis. And then you can get the prostaglandin-associated periorbitopathy. So in this particular patient, the picture that I have up, these two pictures I have are personal patients of mine. And you can see here you can see the pigmentation around the eye. This patient is on a monocular treatment of latanoprost here. You have a deeper superior sulcus here. It almost looks like the eyelid is retracted a little bit because of that. These lashes are longer here as well. And so this is the picture from the poll. And I think there were a lot of people who got this. And this is a more subtle change here, but what you can really see is this loss of fat pad right here when you compare to the other eye. So this patient, this is the eye that's treated, has a little bit of a deeper sulcus. You saw in this previous picture that because of this deepening and making it look like the eyelid is retracted, it actually can make this eyelid look like it's lower, but it's this eye really, that's the issue. So of course, monocular treatment with these medications can make some of these cosmetic effects much more noticeable to the patient. Less common side effects. There are a few systemic things to know about. It's just less common. Patients can get flu-like symptoms, muscle aches, headache. So if someone were to call and say they were put on this medication and they feel like they're sick, that is a legitimate thing that could be from the eye drop, and that would be a reason to potentially change the medication. So just as a kind of summary, most of these side effects are reversible except for the iris darkening. Fat atrophy can cause an untreated eye to appear ptotic, and patients may be bothered by their appearance when they're using this unilaterally. So if I have a patient with a secondary glaucoma and they don't have a contraindication to another medication, sometimes I will try to not choose a prostaglandin as first line. Doesn't mean I won't use it, but particularly women can be very bothered by some of these changes and notice these issues and complain about them. So switching gears a little bit, we're going to talk about these new medications that have been recently approved. We have this trio of medications, Vyzulta, Ropressa, and Rocklatan. And so I'm just going to briefly talk about these and then maybe mention where I think they fall into usefulness in treatment of glaucoma. So Vyzulta or latanoprostene Bunod has a dual mechanism of action. It increases trabecular outflow and uveoscleral outflow. And it is a medication that's broken down into latanoprost and a nitric oxide donator. And nitric oxide basically improves trabecular outflow by relaxing the TM. And so you have this dual mechanism of action. There were several studies that were done that basically showed that Vyzulta can reduce pressure better than latanoprost in the studies. Now, when I say better than latanoprost, you're looking at a point and a half difference, maybe 2-point difference in patients who respond to this. If you have put a patient on monotherapy and you are close to where you want to be and you don't need a huge improvement, but you want a point or two, this is a reasonable thing to try to keep them on a monotherapy and reduce their pressure a little bit more. This is just some pooled data from their phase 3 trials, and their phase 3 trials were done against timolol instead of latanoprost. I don't know why, but just showing that it works quite well diurnally against this medication. And the side effects are really similar to prostaglandins. Vyzulta in general is getting better covered by insurance. They do have a patient assistance program, which if someone is on commercial insurance, the cost is not that bad for this medication. So again, if you're trying to keep someone on monotherapy and you're already close to your goal with a prostaglandin, then this might be something to consider. It is very well tolerated by patients. And then we have the Rho kinase inhibitors or ROCK inhibitors. And in that class, we have natarsadil, which is Ropressa, and Rocklatan, which is natarsadil with latanoprost. And this medication targets the trabecular meshwork, increases outflow, it decreases aqueous production, and also decreases episcleral venous pressure. And these are the ways that it can lower pressure. And their trials were the Rocket 1 and Rocket 2, which were again both done against timolol. And it basically really just showed a non-inferiority to timolol. So you can look at this and see that it's not that it's drastically lowering pressure more than timolol. However, the one thing about this class of medications is that it is a novel mechanism. It is targeting a different pathway compared to our other drops. So potentially as an addition to a medication, it may help. And the common side effects of the ROCK inhibitors are hyperemia. I found in practice that seems to be the biggest reason patients don't want to take the medicine because their eyes are really red, almost, I think, 50% of the time. They can get these subconjunctival hemorrhages. They're generally small and close to the limbus. And they can get corneal verticillata. And so that is a really common thing to see. Generally starts a month and a half or 2 after starting the medication. And if you do stop the medication, they tend to go away in about 3 months, generally not visually significant. And the real rare side effect there's been several case reports now of this is this reticular bullous keratopathy that can develop with this medication. All the reports describe it as kind of a honeycomb appearance, and it's typically in the epithelium. And so here you can see on the OCT these pockets of fluid that are right on the surface of the cornea. And then stopping the medication typically causes resolution. Most of the reports of this have said that it tends to develop more inferiorly in the cornea than centrally, but if it is central, even though the keratopathy goes away with resolution, they have reported some decreased vision after that was permanent from corneal changes. So this is another thing to just know about. And last thing I'm going to discuss, this is not a topical medication.
A couple quick questions maybe to
Okay.
Interject here.
Sure.
First question is, any experience with similar side effects for Lumify as with the 0.2% bromonidine?
I have, yes. I think that you can see the side effects. You can see the development of an allergy and a follicular conjunctivitis. So yes.
Second question is, how do you treat the periocular hyperpigmentation that can develop?
I don't know if Joel has any treatment that's different from stopping the medication. I mean, if it's really bothersome to the patient and you stop the medication, it goes away. I'm not sure that there's any, I've never treated anyone with anything else except stopping medication if they're extremely bothered by it.
And then third question is, so patients with keratoconus or have had a penetrating keratoplasty,
Yep.
Are you worried about using a carbonic anhydrase inhibitor in those patients?
So I try to avoid them. If I'm taking care of cornea patients, I will try to avoid them. I mean, there are some situations in which you get to a point where you're either going to try something like that or do something surgical, and surgeries are not good for the endothelium either. So I won't say that I won't use them, but I won't use them initially. I'll for sure use other things first.
Great, thanks. Oh, actually, well, here's another great question that just popped up. Do you have any concerns about using scleral lenses on glaucoma patients?
It's a really interesting question. For a while, I had questions about whether patients' pressures go up related to scleral lens use. I would say at this point, no, I don't think there's any really good evidence that it causes an issue. It is something that's taken into consideration if a person is going to need some sort of surgical intervention and where and how you're going to approach that. But just saying that I don't think it's a contraindication to using a scleral lens. No. Okay, so I'll move on. I hope that those questions were answered well. So the last thing I'm going to talk about is this new implant Durista. Durista is basically a sustained release bimatoprost implant that is placed intracamerally. It's based off of Ozurdex. So it's a medication that basically dissolves over time, and it delivers 10 micrograms of the drug. It's given through a 28 gauge needle. It can be done at the slit lamp, or it could be done in a minor procedure room or in an operating room. And it was approved last year for currently a single injection. On average, it did lower IOP pretty well in the range of Lumigan or bimatoprost. And interestingly, they saw IOP lowering in a very wide range from 4 months all the way up to 12 months with injection of this medication. And, of course, the reason people are interested in treatments like this are to remove this issue of compliance that we know is a huge problem for patients to take daily medications. And it also doesn't cause a fat atrophy, and potentially may reduce IOP fluctuations. That's a theoretical advantage. I don't think it's been proven out, but of course you have a sustained release medication as opposed to something that's being dosed where the medication could potentially be wearing off at some point. But there are some cautions or some concerns about endothelial cells with this medication. Their first study endpoint, they didn't show any difference with endothelial cells between a sham and a treatment group. However, at 20 months post injection, there was a trend towards increased endothelial cell loss in treated patients. And that is the reason the medication was only approved for a single dose at this point. And it is a contraindicated in patients with a compromised endothelium or with narrow angles because of a concern that the pellet should be settling in the inferior angle, but in a narrow angle, you don't have as much space and it will likely be touching the cornea inferiorly. So, having a single dose medication presents its problems because our patients have a chronic disease. And so potential patients that might be good candidates for this might be people who you think are going to have a temporary pressure issue. So they have some sort of post-operative IOP issue that you think is going to resolve because of a usually steroid taper. In theory, some steroid-induced issue in a patient who has really bad ocular surface disease. And the great thing would be if we had a treatment that could be ongoing for patients who are non-compliant for a variety of issues, not just that they not sure the medication is working, but patients who live by themselves and have dementia, they're forgetful, they have arthritis, they can't put the drops in properly, they can't get the drops in their eye. There's a whole host of reasons why people are non-compliant with medications. And so having some sort of treatment would be amazing for these patients. So this is just something that is currently approved. It's not a perfect solution to these problems that we have in treating glaucoma. I'm just really briefly just mentioning these. These are things that are in the pipeline right now of sustained release medications. And at the top is an intraocular implant that's placed similar to an eye stent that has a drug that is basically pooled in this implant and it slowly releases over time. However, this requires that when the drug has worn off, you remove it and replace it or somehow refill it and it's inside the anterior chamber. There are punctal plugs being looked at, but there are lots of problems with punctal plugs, how well they release medication in a very sustained manner, retention rates. This is a travoprost plug that I put a picture of. It is kind of modeled after Dextenza, which I think Micah is going to be talking about in his talk. And then at the bottom is this bimatoprost ring, which is this ring that fits in the fornices. And surprisingly, as uncomfortable as that looks in some of the trials that have been done, patients are relatively comfortable. And this is something where they can change what kind of medication is in the ring. They can change the dosage of it. So this is a phase 3 trial right now. And just a final thought, I am not at all plugging these pharmacies, but just to know that out there are options of compounding pharmacies that can make medications mixed together for you. And the issue with this is always cost, but on a patient who is on 4 different glaucoma medications, these compounding pharmacies do make formulations where the drops are mixed together and they can take drops as infrequently as 1 drop in the morning and 1 drop in the evening of these mixed medications. And so just a final thought of something to consider that might be helpful in just certain situations. And that's the end of the talk for me. So any other questions I'm happy to answer.
Yeah, so a couple questions popped up. So one question is, could you talk about Rhopressa again? Do you feel like it's best used as a first line or best used as an additive drop?
So I personally have used it more as an additive drop. I think prostaglandin analogs are better at reducing pressure than Rhopressa is. Rhopressa is more similar to timolol and prostaglandins are better than timolol. So I don't typically use it at a first line. I think going from a prostaglandin to Rocklatan is a potential thing you could do. And I think you can get a benefit there. I have had real problems with patients willing to stay on the medication because of the redness though. So, we're lucky we have some samples and sometimes I'll sample the medication out. I think In general, I've started putting people on it later because of the high rate of dissatisfaction with the hyperemia. And so I've been giving it to people sometimes as an additive when they're already on multiple drops trying to avoid, and the patient's trying to avoid surgery.
I guess and a question coming from me. Do you, if cost is not an issue, is there any reason not to use the Vyzulta instead of just latanoprost by itself?
I don't think so. I think cost is the biggest issue. If it was slightly better covered, I would be open to using it as a first line option. I mean, it essentially is very well tolerated, side effect profiles no worse, and potentially works better. So the big thing is getting patients the medication.
Let's see. So another question that came in, great question, is what's the current thinking on a patient with field loss due to optic nerve head drusen? Is there a benefit to lowering the IOP or helping in neuroprotection, or what are your thoughts on drops
Yeah.
for those patients?
Yeah. So I think you fall into a difference between data and personal opinion on this. I don't think that there's data that suggests that lowering IOP helps with field loss in these patients. But I personally don't like to have patients with optic dystrusion have ocular hypertension. It's very hard to tell whether they have glaucoma or not. But if they have ocular hypertension or field loss, with at least a high normal pressure, I have a tendency to treat them. I mean, I will tell them that there is no proof of that. It makes me personally feel better to have their pressure be a little bit lower. And so I do tend to treat them, but I don't think that there's good evidence out there for that.
I do the same thing in some of my patients with an optic neuropathy. If they have an optic neuropathy and there's any evidence that the optic nerve OCT is maybe getting a little worse or their pressure's on the high side, I do tend to try to lower their pressure. And I tend to use Alphagan just because of the potential neuroprotection. I don't know. What do you think about, using Alphagan because of sort of their neuroprotective effect?
Yeah, I have offered Alphagan or brimonidine to patients for that reason. Again, I've told them that it's not proven. I try to get an idea of the likelihood that the patient's going to do it. I mean, you're going to a twice a day medication, which is people are not good at that. So I'll offer it, but I do sometimes use prostaglandins, and I tend to optic dystrusion patients oftentimes are younger. I tend to offer them SLT.
Great questions. All right, so I'm gonna steal your screen.
Okay.
Just a quick plug for our fabulous Dr. Werner, who's not here to be embarrassed, luckily, but we personally all think she's the best refractive surgeon in all of Colorado, and we are definitely not biased. I think one of the best things that Dr. Werner does for her patients is sort of the antithesis of the sort of LASIK shop or discount LASIK shop, is that she really takes the time and individualizes treatment for patients. And really in the end, after you get past all the hype and promotion, really LASIK is about the same as you get at a quote discount LASIK shop after you take into account that somebody has more than one diopter of myopia. And she loves doing co-management with you guys, and to help with all the chair time it takes for these patients, she does a 30% co-management relationship for refractive surgery. So presentation number 3 is going to be dropless cataract surgery, what's old and what's new. And I think this is something that's really exciting. And I have to give a shout out to Dr. Rothstein that this has been a little bit of a sort of a shift in how we've done cataract surgery. And he really helped sort of spearhead this with the surgery center, and I think took a little bit of a leap, and the patients are just loving it. So I don't want to inflate his ego too much, so I'll just sort of let him get going. Thanks.
Thanks, Justin, for the introduction. Just want to thank everybody for coming out, or rather meandering over to your home office like I did. It's a Sunday morning, obviously. I think we'd all rather be other places, but wanted to thank everybody for coming out. I look forward to the next meeting when maybe we can see everybody's face again without masks. So yeah, the dropless cataract surgery, it's been around, for a while. I'm sure you guys have been hearing about it. You probably have even co-managed patients that have had dropless surgery. But I would like to kind of explain why me personally, I've sort of sat on the sidelines for a while and what my rationale is now for joining the trend. I'd like to say that I don't have any conflicts of interest, so I'm not a speaker for anybody. So just wanted to point that out. So I'm going to quickly, without boring you in too much detail, about the data on endophthalmitis, but I would like to review it because in preparing this talk, I was, I just wanted to remind myself what the data was on endophthalmitis prophylaxis was, and whether it warranted moving to a dropless option. Certainly want to describe the problems we have, and everybody has, including the patients as well as the providers of limitations of post-op medications. And finally, I'd like to try to review the state of the art of dropless cataract surgery. Endophthalmitis studies, they're hard to do. I mean, they have to be, significantly powered because the rates of endophthalmitis postoperatively are so low. Powering a study like this is tricky. It requires a ton of patience, a lot of manpower, a lot of time. And so we finally have one really good sort of gold standard prospective double mass placebo-controlled study. Most of the studies are observational. And I would like to point out that still nothing is perfect with drops or dropless. We have problems both ways, and I don't want to paint dropless as the end all be all, but I think it's been working well for us now. And I'd like to kind of go forward from there. So everybody is familiar with the common drops that we use. I put in lubricants there as well, but I think everybody would agree that an antibiotic drop is an antibiotic drop or an antibiotic, whether you use it intracamerally, intravitreally, no one would probably disagree that an antibiotic is necessary. The steroid and NSAID debate, the regimens vary wildly. Even amongst our group, we try to have sort of a standard of care, but we have a hard time sort of agreeing on, what the regimen should be, what patients should get a steroid alone, which patients should get an NSAID, whether those just high-risk patients, for example, with diabetes and macular pathology, retinal vein occlusions, are those the ones that should get an NSAID as well? So we have a hard time, even amongst our group, sort of agreeing on a standard of care. And so it is a little bit of a Wild West out there with what people do between their steroid and NSAID. Nobody, I don't think, is going to go out and say you don't need an antibiotic. But as far as the NSAID and the steroid, I think it's a surgeon preference. And I think everybody out there has seen kind of wild deviations in this. And I can certainly understand, make it hard for co-managing and understanding what the patients are. And the last thing you want to do when you have a patient sitting in your chair is sort of not know exactly what regimen they are on. So of course, why dropless? And these bottles are all generic looking bottles. The patients, I've seen patients put, one cap on a different bottle, confuse them that way. And the goal is to prevent the confusion of multiple bottles. We have gone to mostly a compounded regimen where we'll have a single bottle with 3 drops initially, and then a single bottle with 2 drops for weeks 2 to 4. That's helped a lot. Some patients don't want to get the compounded drops, mostly for cost reasons. But the goal is to really try to prevent the confusion of multiple bottles, and also to try to prevent the multitude of issues that patients have self-administering. I'm always reminded of a funny story when I was in glaucoma fellowship at this point. We had probably a 48-year-old African-American woman in the glaucoma clinic who was referred for first-time diagnosis of glaucoma. We made the diagnosis, we went through the treatment options, decided we would put her on a prostaglandin, came back in 2 weeks, the pressure was completely unchanged, it was a monocular trial. Okay, well that happens about 10% of the time. We put her back on to a second class of medicine. I think we chose a beta blocker, brought her back in 2 weeks. Same thing, monocular trial, no effect. So third class of medicines, I think we went to Alphagan, came back 2 weeks later, nothing. And finally, I was sitting here after the third try, and I thought to ask her how she was using her drops. And I'm not kidding you. She took the medicine took the bottle out of her purse, and she put it in her mouth. So she was thinking that obviously the drops were to be used orally. And so it's just a reminder that patients are notoriously inaccurate with how they take it. There's cost issues that get in the way of patients taking their medications. There's side effects. And ultimately, it's about really having, I think, satisfied patients. And that's sort of what's pushed us to going into this dropless regimen. So I'm purposefully showing you the most intensive drop regimen here. This is an example of a sheet we'll give patients as a compliance aid. And for the first 7 to 10 days, including what we used to use as preoperative medications, there was, if you count it up, it's 110 drops. Weeks 2 to 4 are 126 drops. And so this is a total of 236 drops. And that's, of course, just one eye. And, we typically do the second eye 2 weeks later. So, of course, you're talking about an enormous amount of drops. And, of course, I purposely showed you the most intensive regimen of a 4-time-a-day antibiotic and 4-time-a-day steroid and non-steroidal. This is not always what people use. There's certainly other ways around that. But at its worst, you can see that there's over 200 drops per eye. So ultimately, we're trying to help this. And really, I just showed you this picture of just a perfectly nice, white, quiet eye. And that's the goal, is to get happy eyes that see well quickly, that are comfortable. We obviously want to prevent infections and inflammation and pain, and have people with smiles on their faces. So the current regimen for antibiotics, at least intracamerally, and some of these are topical as well. These are the 4 types that are generally used: cefazolin, cefuroxime, Vanco. But as Dr. Canoff pointed out, that's no longer used due to HORV, and moxifloxacin. Mainly, cefazolin and cefuroxime, those are first and second generation cephalosporins. Vanco and Moxi are both, really powerful against gram-positive organisms. Vanco for MRSA, Moxi's, very broad spectrum. None of these are perfect. There's all resistant strains, but what's important is that these antibiotics are bactericidal, and they're not bacteriostatic. So you want an antibiotic that's going to kill bacteria, not just sort of pause it in its tracks. So obviously we use the antibiotic to prevent endophthalmitis, and there's not many randomized trials. There's many observational retrospective designs, which have their limitations. The betadine prep is by far I think, the most effective way to reduce the incidence of endophthalmitis. I'd like to remind everybody, 70, most infections, I think it's over 90% are some gram-positive, probably normal skin flora. 70% are coag-negative staph and 10% Staph aureus. You've got another, 9% or so that are gram-positive cocci. 5% might be enterococcus. And a small percentage are gram-negative, but these are all bacteria that, with rare exception, these are all going to be cases that are acquired from the patient's sort of normal skin flora. So just without going into too much detail about the data is out there, I wanted to, just in my research in preparing this, is that there's a few studies. I particularly picked out a couple from India, from the Aravind Eye Hospital. If anybody doesn't know about it, this place is unbelievable. This study here, it's from 2016. A lot of eyes, 116,000. The next one I'm going to show you is over 2 million eyes that they looked at retrospectively. There were 3 arms in this study, and the one arm with intracameral moxi showed a 4-fold reduction in endophthalmitis. This is the 2 million consecutive cataract surgeries. And once they started using intracameral moxi, the rate went down from 0.07% to 0.02%. So that was statistically significant. This was an interesting Spanish study over 10 years looking at, it was the first 7 years, there was no antibiotic used. The rate was 0.59, 0.6%. And then the last 3 years of the comparative study, they started using intracameral antibiotics, and the rate dropped dramatically, 0.043%. So those are the rates that we really want to see. It's a rare event anyway, but it's a catastrophic event for patients. So we want to get it as low as we possibly can. And so that all led up to what is sort of the landmark European study trial, which was of course really well designed. It was the very large randomized prospective study whether intracameral antibiotics versus topical antibiotics were effective in reducing post-op endophthalmitis, and no surprise, almost a 5-fold reduced risk of endophthalmitis. And the other interesting thing that came out of that was the other risk factor of endophthalmitis was a silicone IOL, which showed a threefold increased risk. And we personally don't use silicone IOLs. They do work fine. Optically, they work well. They can have less dysphotopsias, and they're easy to handle. But with the modern acrylics, we've gone exclusively to acrylic IOLs. So it's just amazing to think, about a study like the Aravind study that had over 2 million patients. That really nailed it down that intracameral antibiotics do make a big difference. So there's little doubt that they do work. The other drops, the steroid and the NSAID, of course, we use them to prevent inflammation, reduce pain, speed visual recovery, all those things. But there's really not a ton of evidence-based studies showing a difference between, say, a steroid and an NSAID. The common steroids everybody knows are prednisone. Dexamethasone we don't use a ton. It's a very inexpensive medicine. And it's very well tolerated. It just has a high incidence of steroid responders. Loteprednol, there are studies of loteprednol that actually are effective in reducing pain and inflammation following cataract surgery as well. So there's no right or wrong answer with what steroid eye drops to use. What we see going forward is that there's other ways to administer steroids that can be just as beneficial. In NSAID, same exact slide, I just copied it. Prevent inflammation, reduce pain, speed recovery. We all know about ketorolac, Acular, Levro, Prolenza. And of course, I mean, this is all basic science here, but steroids inhibit arachidonic acid pathway way up at the top by inhibiting phospholipase A2. And the NSAIDs are effective at the left side, the cyclooxygenase pathway. So the steroid is inhibiting much more downstream inflammatory mediators, and the NSAID is a little bit more selective to just the cyclooxygenase pathway. People forget about lubricants. Lubricants are still actually an amazing tool to use after cataract surgery. They reduce pain, they speed visual recovery, and ideally you want to have something that would be non-preserved. So getting into kind of the advantages now of what we are trying to capture with dropless, the main thing is really compliance. You know, a lot of studies have shown with complex regimens that you can get 40 to even 90% rates of non-compliance depending on how you define it. So the more complex regimen, the less the compliance is going to be, and we know that from glaucoma medicines as well. Costs can be a major problem with drops. And it's often now that coverage is expanding an advantage of dropless surgery. I mean, some branded, drops can cost, we see price tags in the $600 realm. I mean, that's not always the case. But if you are a believer in branded medications only, some patients are looking at pretty hefty price tag.
An interesting comment about the cost is that the drops that patients pick up are either run through like Medicare Part D or through their prescription drug coverage, which can be dramatically different. Whereas the medicines we use for the dropless are run through Medicare Part B or through sort of their surgical benefits. So it's a completely different section of the insurance that the patient utilizes, even though they're sort of doing the same thing. It's sort of an interesting insurance to navigate.
Yeah, and that's been one of the challenges just for our office, but we seem to be handling that fairly well. Side effects of drops are numerous. Everybody knows about stinging, potentially taste, of course, keratitis after you've been on ketorolac for a month certainly can cause a keratitis. Theoretically, and I said perhaps, there'd be less antibiotic resistance due to the fact that patients using dropless don't have to worry about starting and stopping and perhaps an incomplete treatment that they might get from using drops. This has been a huge thing, and it's really starting to come to fruition now that more of the providers are doing it, but we're getting a lot fewer office calls. And this is really, I mean, as silly as it sounds, we're all very busy. And this is translated to staff satisfaction. A lot of, even amongst providers, a common call over the weekend for the on-call doctor is to fill the medications or to clarify medications when they started. Patients saying, "Oh, I forgot to start my medication." So this has really changed things a lot, and just the practical nature of it has been another plus. And then ultimately, patient satisfaction is what we're all after, right? Happy patients are easier patients. They give us satisfaction. They give us meaning in our life. Literally, it's why we do what we do. And I've had now probably a small handful of patients who had one eye done before the pandemic and had to get delayed because of COVID. And their first eye was done with drops. The second eye was done dropless. As you can imagine, these patients are, they're singing the praises of the dropless regimen. So just to reiterate again and show you that complex schedule, hundreds of drops over a month, multiple chances for non-compliance, the possibility of antibiotic resistance, bottle contamination, epithelial toxicity. these are all the advantages of a dropless regimen. And it's not perfect. As you can imagine, there are some disadvantages. Otherwise, everybody would be doing it, and there'd be really no choice. But potentially, a disadvantage could be cost, particularly those patients that may not have the drugs covered. They're part, for example, some of the Dextenza, Trimoxy, some of these are hundreds of dollars, and I've had patients that where the drugs were not covered and they wanted to use them anyway. But they can be pretty costly. The intracameral antibiotics, they cost the surgery centers. That's hard costs. There's no reimbursement for the antibiotics, but cost on both sides, the patient and the surgery center. So anatomy, not everybody can have, for example, a punctal plug put in. The punctum needs to be intact. There's always a chance for epiphora with a medicated punctal plug. And some of the other anatomical concerns are with, for example, Trimoxy. It goes in as sort of a suspension, and so the visual recovery can be affected. There's temporary effects on the vision, a lot of floaters sometimes. Typically, it's just a few days, but we all want patients to recover and recover as speedy as possible. So some of the treatment options available do affect the vision. There's always the chance for breakthrough pain. You can have inflammation that still require an NSAID or sort of a steroid rescue. And so this buzzword of dropless is a great word, but also you could turn that around and just say less drops. So some patients, instead of having that hundreds of drop regimen, perhaps could go to an NSAID, once or twice a day. So it's not dropless, it's less drops, and that still is a help to patients. There is the potential for any drug that's injected into the eye for TAS, toxic anterior segment syndrome. Those would come from dilution errors, medication errors, other toxicities. So as Dr. Canoff mentioned, that vancomycin toxicity. So there's always the potential for those. And for those of you who may not know, TAS is a severe, vision-threatening problem with corneal edema that sometimes doesn't recover. So there is always that chance when we're injecting a medicine into the eye that you can cause more harm. We haven't had a significant outbreak in TAS since the early 2000s when there was an outbreak linked to a contaminated bottle of irrigation solution. So, we just have to make sure that when we're using, compounded medications for intracameral use, that we have a reputable pharmacy, but it is still a possible disadvantage. And then there's always a steroid response. So when we're giving medicine into the eye, it is a lot more difficult, a lot less easy to pull this medicine back. So patients that get a steroid response are known steroid responders. You have to be careful with this, particular ones that are on the glaucoma spectrum. Next part of the talk will be actually, discussing the options that are out there. Early on, there were collagen contact lenses. That was a concept when I was in fellowship in the early 2000s. One particular one was embedded, the collagen shield embedded with Tobradex. Half the time, so we were involved in a study, and half the patients were randomized to get it, and the ones that had it, we would perform our surgery. We would put the contact lens in the eye. It was a real, for those of you who used them, they're very, very sort of slimy and soft, not like a typical bandage contact lens. And we would put these in at the end of the case. We would put the patch on, And I think half the time the next morning when we took the patch off, the contact lens was sitting on the eyelashes. So these things didn't stay in very well. So that quickly has fallen by the wayside. The modern options are Trimoxy, Dexmoxy, and that can be given intravitreal or transzonular. There are intracameral antibiotics that are used, mostly cefuroxime or moxifloxacin. You can use intracameral steroids like Triessence. Dexacu is a modern steroid that's a small sort of almost it's not really a pellet, but it's a slow released dexamethasone. And then with Dextenza, that is the medicated, the dexamethasone punctal plug, that when it was approved, that started the one that really started getting my attention. And then the other medicine is Omidria. And Omidria can help take the place of an NSAID. And it's a combination of an NSAID, ketorolac, and phenylephrine. So it does help to maintain pupil dilation during these cases. So this is an example. This is Trimoxy. Excuse me, sorry. This is how Trimoxy goes in. It's a combination of triamcinolone and moxifloxacin. It's generally given as a pars plana injection, or it can be given transzonular. But when this medicine goes in, it does go in as a fairly big cloud. And depending on the liquefaction of the vitreous, it can sit in a not so good location. We would generally try to give this inferiorly, so as patients sit up, it would drift to the outside. But it was given as a bit of a cloud. Let's see if I can get this. Yeah, this is the video I wanted to show for Trimoxy. So this is post-cataract surgery. You can see the IOL is in place. This is intravitreal injection, as everybody knows.
So we actually can't see the video.
You can't see the video?
Maybe if you, I think you might have to reshare a different part of, like the window that has it playing.
Give me a second here. Anything yet? No?
Yeah, now we can see the window.
Okay, hold on. Yeah, this video is, this is not my video, obviously.
Yeah, we can see it now.
Okay, perfect. So this is an intravitreal injection of Trimoxy. So the cataract has been done. The IOL is in place. And as the Trimoxy goes in, you'll see the cloud going into the vitreous. So you can imagine what effect that might have on the vision if that cloud didn't dissipate. Most of the time it does, but this was one of the reasons that I was not super excited about Trimoxy as an alternative. Getting back here. So Dexacu is another alternative that's recently been FDA approved. It's a small amount of dexamethasone. And on the right side of your screen, you can see a Dexacu that was recently implanted, and it migrated to the anterior chamber, so you can get a sense of the size of this thing. But it delivers a small amount, 517 micrograms of dexamethasone to the anterior chamber. The best technique is to really get this behind. So again, after cataract surgery, the implant is in, is to get this into the sulcus. So you can see that little pearl there has been has been injected. And then that little pearl slowly elutes the dexamethasone over a month. But as in this right-sided image, there's an implant that's migrated in the anterior chamber. Generally wouldn't cause a problem, but you could get some focal peripheral anterior synechii right there. And of course, you'd have to warn patients if they look carefully, they might see that little white blob. But that's the DEXA-Q, and the DEXA-Q has, there is a few case reports of a DEXA-Q adhering to the intraocular lens. And obviously you would not want that, especially centrally. So that was, when that came out, that also sort of didn't get me that excited when I heard reports about that, although this is gaining a lot of popularity as well. The other compound we use is called omidria, and this is a during surgery infusions, phenylephrine mixed with ketorolac. It's been around for a while, and it was approved to control pain and reduce miosis during cataract surgery. So it is actually FDA approved. This company just got extension of their pass-through status because it's a pain medication that's non-opioid. And there's a big push for non-opioid pain relief and pain management. So omidria was lucky enough to get a pass-through status and continued payment through Medicare based on the fact that it's a non-opioid pain medication. So Dextenza is what we've started to do. And it was approved in November of 2018 for specifically postoperative pain and inflammation. It delivers 0.4 milligrams of dexamethasone into the lower or upper punctum, and it's a dissolvable plug. So everybody is familiar with how to put these in and how they work. The steroid is eluted over 30 days and the scaffolding dissolves over 60 days. So these patients also get the secondary benefit of having a bit more tears, which I think also can be helpful on the ocular surface. The data for Dextenza is good. I wouldn't call it phenomenal. And it's certainly better at treating ocular pain, which is fairly rare after cataract surgery, than clearing cell. And in a couple of studies, the 80% of patients receiving Dextenza versus 43% that received just a non-medicated plug were pain-free at day 8. So, half the patients didn't feel, almost half, 43% didn't feel any pain anyway, but there was a significant reduction in pain control using the Dextenza. Clearance of cell was less impressive, and I would have to agree with this study, just anecdotally in my own practice, about the clearance of cell is not as good, I don't think, as topical medication. 33% of the Dextenza arm versus 14% of placebo were cell-free at day 14. So that's not very impressive. And, you could argue that a little bit of cell floating around might be harmless at day 14, but I think the jury is out on that. And about 5% of people in that study had an IOP rise greater than 10 millimeters of mercury. So this is my own video, pre-surgical video of putting a Dextenza. And as you guys know, nothing super exciting about this, but it is important that the area be well dried. So this is what I'm doing now, just drying the punctum. And this is happening before surgery. You can easily do it after surgery as well, but just I don't know, for flow, I've kind of like doing this now pre-surgery. So the patients are not prepped yet; they're numb. There you see, we just pull the lower punctum down. It's important to sort of stretch the lower lid laterally to get some counter traction, and then it's not a particularly large dilation, but it helps if the dilation is bigger. The Dextenza hydrates very rapidly. So, you want to dry very well, but it's hard to dry inside the punctum. And so as soon as the Dextenza goes in, you'll see me loading it here. So that's it. It comes in just a little sort of styrofoam, thin sort of styrofoam packaging with the Dextenza just protruding out. We grab it just by the tip and then insert it. And what you won't see here is the rapid hydration of it, because this one goes in very quickly. But within seconds, you can kind of just see it starting to hydrate there. And we're putting it just underneath the lid margin. We want to try to keep it as close to the lid margin as possible, just because the proximity is better on the ocular surface. So that's it. It's simple. There's no cloud of white that goes in. The patients are getting a little benefit from the extra tearing, and it's a procedure we're all real familiar with. Dextenza is looking at other indications as well. Just as a side note, they're looking at ocular allergy as a possible indication, as well as like anterior uveitis. So those studies are ongoing. And I decided to just kind of look back and see what's happened so far. We started in September, I believe, maybe a few in August, but full bore in September. And all eligible patients, we changed our own regimen to use a Dextenza implant, Omidria during surgery in the irrigation bottle, and intracameral moxifloxacin. So far, we have 146 patients. I have no cases of endophthalmitis. 3 patients have been in need of rescue for an NSAID just for pain. And this one is a little concerning to me. I think time will tell, but I have had so far 4 cases of CME. One of those cases was bilateral, and the other 2 had no additional risk factors like diabetes or vein occlusions or macular pathology. So that's a high rate of CME compared to what you look at the literature, which should be less than 1%. Fortunately, all cases responded to topical NSAID, and I've had, which is surprising, no steroid responders, 0. Considering I have a high population of glaucoma patients, I've had no cases of steroid response at the moment. And just a word about steroid response. In general, you'll see about 1/3 of the population will show the moderate response, defined as 25 to 31. About 5% will show severe response, pressure greater than 31, and 2/3 really will generally show no response. Of glaucoma population, those numbers are higher, and it's up to 40% of patients will show that 25 to 31, and 10% can get over 31. So there's not a ton of good data. I did actually have some notes. There's not a ton of good data on the rate of steroid response, and what's out there to me is actually a little suspicious, because the DEXA-Q showed 0, like a mean intraocular pressure equivalent to a vehicle, like a placebo vehicle, which is surprising because dexamethasone is one of the most potent steroids we have, and you would expect more. The Dextenza really showed a small, like a 5%, which is in line with what you would see with the general population. I have not seen it. So it's interesting that I find it interesting that there's some of the steroid response data with the steroid injections or the Dextenza are kind of, we're showing less steroid response than would be expected. And it makes me wonder, especially for example, Dextenza, really how much dexamethasone is getting out onto the tissue. But it's not been a problem in my own personal experience, and the limited data suggests that it's not an issue at least a significant issue yet. So I've been pleasantly surprised with that. And I think that's all I have, unless we can go ahead and open it up for questions.
So we got one question. So one question is, if a patient has silicone punctal plugs, do they need to be removed first, or is that something you can do intraoperatively, or how would that work?
Yeah, that's a good question, and I have encountered this situation a couple of times. I've removed the silicone plugs at the time. I usually am not a big fan of occluding the upper punctum, although you certainly can do that with Dextenza. And I've done that. Some patients have a very tight punctum, and we go to the upper side. I had one patient that I could only get the Dextenza about halfway in. I trimmed it and left it, and then it actually started to elute on their first post-operative day. I just took it out because of comfort. I put that patient on ketorolac only because we had a sample in the office. And that patient, and then I treated her other eye that way because she did have a punctal plug. I didn't do the Dextenza. I just kept her on ketorolac. And after a week of 3 times a day ketorolac, she was totally quiet, happy, good vision. So I think we tend to overdo a lot of steroid and NSAID after cataract surgery, but I would remove the punctal plug and go from there.
Yeah, and I think something that's been interesting when we were doing this sort of experiment or trial is I think we all underestimated the amount that it bothers patients to use drops. I think we all thought that, yeah, this was something interesting. Maybe people would like it. Maybe people wouldn't really want to do it. But I think we've been surprised at how excited patients are to not use their drops and how much that bothers them, and just really how happy they are. I mean, I certainly was surprised. I mean, obviously we wouldn't have done it if we didn't think it was beneficial, but I've just been shocked at how excited people are about not using drops.
Yeah, I anticipate it is going to be, if ever there is going to be a standard of care, this at some point will be standard of care, mostly because it's effective, it's safe, it's not perfect, but patients will start to ask for it because it's going to be the expectation. What I have typically seen, just in case, as you guys co-manage these patients, I do typically see a slight little bit of more conjunctival injection. It's not bad, but a little bit of conjunctival injection over topical therapy, and a little bit more cell at week 1. And I think just to be on the lookout for those things and know that it's probably fairly typical. And time will tell, but also my suspicion that there might be higher rates of CME will maybe be borne out, but we're not quite sure of that yet. One thing that's interested me is, again, perhaps going just to a less drop surgery and maybe putting one of the modern types of NSAID on once a day, and that certainly would be helpful to patients as well. I think they would love that, and that may counteract what I'm suspicious might be a little higher rate of CME.
Any other cataract surgeons have thoughts?
Yeah, this is Dr. Myers, and I, number one, want to thank Dr. Rosting for taking the bull by the horns and initiating this within our practice. There's a lot of effort that goes into instituting a new approach, and there's a lot of bureaucratic things that also need to be dealt with. A huge amount of effort on obtaining pre-authorizations through patients' insurance, which our staff has helped out with quite a bit. So that's been great. The rest of us have been doing dropless as well, and the patient satisfaction is truly huge. They really like this, and that is important. One thing that I feel like I've noticed is that my patients in the post-op week number 1, they do seem to have just a little bit more surface inflammation, as Dr. Rosting noted. and also a little bit more corneal striate keratopathy, potentially a little bit more corneal edema. And, you know, when you have a patient who's having the second eye done 2 weeks after surgery, if there's a little bit of a delay in the improvement in their vision, they may get a little bit concerned over that. And I've had a couple of patients where I've initiated some steroid eye drops to speed that along a little bit, perhaps.
Yeah.
Another comment I want to make is that in the drop regimen sheet that Dr. Rothstein showed, that is our most rigorous regimen. And the reality is we do have a large number of patients in the past who, through a compounding pharmacy, have been utilizing drops such that it has only been 4 times a day. So there are patients who have insurance programs where they are going to make certain that they use their insurance for their eye drops, and they may end up getting what I call the triple whammy, where you have the antibiotic, the steroid, and the non-steroidal anti-inflammatory, and it is very onerous.
Yeah.
Punctum, because the lower one has been blocked, and now you're potentially getting the Dextenza into the tears. However, you're not getting drainage at all, and so that's something I've been considering quite a bit, and I may alter my approach utilizing more of the other removable implants for occluding puncta. You know, the Dextenza implants, Dr. Rothstein, correct me, they're supposed to last for just about 3 weeks or so.
The medication part is for a month, but the scaffolding is actually, according to Ocular Therapeutics, can last 2 months. So you can get some continued epiphora long after the Dextenza, after the dexamethasone is gone. So I kind of agree with you. If someone had lower lid punctal cautery, I would have a long discussion with that. I probably would lean towards not doing it in the upper punctum, and probably counseling them that they should go on perhaps a compounded drop for compliance reasons.
You know, a lot of these patients, if they're really quite severe in their dryness, they're probably not making virtually any aqueous. And so for some patients, it didn't matter. I can remember 30 years ago, and that shows how old I am, where we would block upper and lower permanently. And a lot of patients, they were so dry, it virtually didn't make a difference at all. But we got away from doing that many years ago.
All right. So presentation number 4, lifting the lid on blepharoplasty. I did not do a good job with coming up with a witty title. I'll have to work on that next time. All right, Joel, you are on.
All righty. So as Monty Python would have said, now for something completely different. So thank you everyone for
You might, because we're seeing it as the presentation mode also, you might want to click on that button where it says use slideshow, maybe in the upper left.
Upper left.
Did that do anything? There we go. Okay,
Oh,
yeah,
okay,
so now we can see it filling the screen.
Awesome, but I lost my slide. Give me one moment here. And I lost my presentation mode though when I did that. So how do I undo that?
Maybe escape.
I'm going to stop the share for a moment. And
So one question from the audience when we're looking here, maybe Dr. Parikh or Rothstein, do you have any thoughts on using omega-3s for your severe dry eye patients? And do you find that helps or doesn't help? They've both muted themselves, so maybe the answer is
Sorry. I haven't personally been that impressed with the orals, and I think there was some data that came out that was pretty mixed about whether orals work, but I don't know. I think when people get to that real severe stage of dry eye, I usually have somebody else helping me. So someone else might be able to answer better than me.
well, actually, I think our dry eye expert is Jane, and she chimed in and she says that that she puts a lot of her patients on Retain instead of omega-3s. And I do have to put a shout out for Dr. Wolford. She does an amazing job with our dry eye patients, and a lot of us make, especially in retina and glaucoma, make extremely dry eyes for her to treat. So yeah, so her go-to is she's saying she would suggest Retain. So while Dr. Myers is still sort of figuring that out, one interesting thing about Dr. Rothstein's talk is he was talking about the endophthalmitis during cataract surgery, and there's been a lot of something you wouldn't necessarily think is controversial, but there has been some controversy on the use of intracameral antibiotics. That European study that Dr. Rothstein showed back in 2007 really was received very differently depending on which side of the ocean you were on. In Europe, it was basically pretty universally led to the adoption of the use of cefuroxime for cataract prophylaxis. But it was a much frostier reception in the United States, and I think there was really two reasons for that. One, if you really drill into their data, they showed a really nice reduction in the rate of endophthalmitis, but the criticism is that their baseline placebo group had a relatively high rate of endophthalmitis to begin with. And that was also interestingly in that study that he showed from Spain. So that was one criticism, is that their baseline rate of endophthalmitis was very high to begin with. But I think really the main hesitancy to adoption in the US was the fact that there's a commercially available cefuroxime for intracameral injection available in Europe. And that's not available in the United States. So it basically involved compounding medications. And back in 2007, the getting compounded medications for the OR was much more difficult and a lot more risky. So basically your two options were, is you could take a multi-dose vial and draw a bunch of doses out of it and use that over the course of the day. But then you're introducing the risk of dilution errors, which could cause TAS or even just contamination. And then really the compounding pharmacies back in that time period were not very well regulated. And that sort of came to a head in about 2008, 2009, when there was an outbreak of fungal meningitis. And a bunch of people actually ended up dying. And many of them came from this one pharmacy in Massachusetts, where they shipped this contaminated steroids all around the country. And since then, the FDA dramatically changed the rules on compounding pharmacies and came up with these two different classifications, a 503A, which is sort of your traditional compounding pharmacy where they make, one medication for one patient and sort of ship it around. And then they came with this 503B, which is essentially the only pharmacies that are allowed to mass distribute drugs, which is where we get ours from. And essentially the rules for those 503B compounding pharmacies have essentially become almost identical to what drug manufacturers have to do when they're manufacturing drugs. And so I think that safety has increased all of our willingness to use these compounding medications. And so I think that's led to also the increased adoption in the last few years. All right, so Joel, should I keep talking, or are you?
Well, are you able to see my screen?
Yep. All right, we are ready. So I will hand it.
Okay, very good. So again, thank you for everyone's attendance today on this wonderful snowy morning here in Longmont. It looks like I'm up to about 7 to 8 inches of snow. So it's going to be a tree clearing effort when this is all done. Anyway, about 3 or 4 months ago, Jane Wolford sent me a text message asking me about UNIQ, or UPNIQ rather, and I did some research and I texted her back, well, it looks like I'm out of a job. So the reality is there's a wonderful new opportunity for all of us to provide treatment for patients with blepharoptosis that didn't really exist very well. And I'm excited about it. It's created a little bit more chair time in some ways. We'll talk about that. But it's just really nice to have another option. So we'll get started here. I did my fellowship down in Tucson quite some time ago, and we are very proud of our facilities here in Longmont. We've got the Eye Care Center, and then we have the Advanced Vision Surgery Center, and Dr. Canoff talked about those a fair bit previously. We do have the offices in Boulder, Lafayette, and we share an office in Greeley as well. Our doctors, we've got our 4 retina specialists, Dr. Benedict, Tilton, Canoff, and Manry. We've got our glaucoma and cataract specialist, Dr. Rothstein, Sheth, and Parikh. Dr. Werner, who does corneal refractive and cataract surgery. And I do cosmetic reconstructive oculofacial plastic surgery and cataract surgery. And then we have our comprehensive eye care specialist, Dr. Crone, who can fit a contact lens on pretty much anything I've ever seen. Dr. Wolford, who does an amazing job with comprehensive care and ocular surface disease, and Melissa Burton, our most recent addition, who has amazing fund of knowledge on treating ocular disease as well. So we're really happy with all our group, and we're very proud of everyone. So without further ado, lifting a lid on blepharoptosis. And typically in the past, we had approaches that were basically all just surgical. And I do want to comment that I have received no remuneration from RVL Pharmaceuticals, who manufactures UPNIQ, AbbVie, who has taken over Botox from Allergan. They just bought them. And although maybe I wish I did, after all is said and done here. Anyway, so UPNIQ is oxymetazoline. Its concentration is 0.1%. It's an alpha agonist. And oxymetazoline is the same medication that's been in a lot of nasal sprays for decongestant purposes for many years. On the alpha-1 basis, it has a 5-to-1 ratio of its effects on alpha-2 versus alpha-1. And I'll note that the pupil dilator has mostly, almost entirely alpha-1, so you don't get effects on the pupil with UPNIQ. So question is, when do we raise the lid with UPNIQ? And here's a typical patient, and I will, with complete honesty here, this is my wife, and she has mild blepharoptosis on both sides, and here she is half an hour after using UPNIQ. And if you look, you'll see that as an alpha agonist, it's lifted the lid, and it's also caused a little bit of conjunctival blanching, and those are both positive things for many people. And then the question is when to refer. When do we not use UPNIQ, NoNIQ? And before we can talk about that, we need to do what I would say is the long review of blepharoptosis. Oculofacial plastic surgeons have a love-hate relationship with blepharoptosis. because when you surgically, when you get it right, man, you are just walking on air. But it's not the most predictable thing that we routinely do. So it's nice to have another option, and we'll talk about those details down the road here. So ptosis by definition is an abnormally low position of the upper eyelid margin when the eye is directed in primary gaze. And basic anatomy here on the skin, we've got the skin surface, and then we have the levator aponeurosis.
Is it frozen on everybody's screen or just my screen?
I see him frozen as well.
Okay, so I think it's okay. All right. So let's see. Uh-oh. Looks like he might have disconnected. I hope his power didn't go out.
Right? Yeah, he's talking about all those trees falling down.
Yeah. Hey Micah, do you wanna maybe call him on his cell phone real quick and just sort of see? Hopefully he'll rejoin in just a minute. Again, this makes for a good classic Zoom meeting.
Yeah. Does everybody see?
So I guess while we're working on getting him back online, so just to sort of finish up, yeah, I think really we've all sort of shifted to using more intracameral antibiotics just because of that availability and the safety profile. And so we really use two of them. We're using cefuroxime and moxifloxacin, and we're using the moxifloxacin primarily just because less people seem to have an allergy. And then we're keeping the cefuroxime sort of as a backup for people who would have a fluoroquinolone allergy. And I think the data that's even more convincing than that European study, because there's those valid critiques, is that data from Aravind Eye Hospital in India is extremely compelling because of the huge numbers they have. And the nice thing about that study is that their baseline number of a 0.07% endophthalmitis is already a pretty good rate of endophthalmitis. So doesn't have that same critique as the European study. And then the fact that they were able to lower that is pretty amazing.
Well, the other amazing thing about that Aravind, there's a lot of those patients who are getting manual 6 surgery, basically large and small incision, but compared to phaco, it's a huge incision.
Well, the outer incision is still pretty big, isn't it? Isn't it 5 or 6 millimeters?
Even bigger than that.
I mean, I would say that's a big incision. Yeah. Yeah. The Aravind I mean, I guess while we're waiting for Joel to come back on, the Aravind Eye Hospital is really amazing. If anybody has any interest in like international eye care or just like a case study in how you take care of a population, what they do is amazing. I mean, they're probably doing 10 or 20 times the volume of cataract surgery, that centers here do, and they do it amazingly fast in ways that just we wouldn't think would be acceptable in the United States, but they have fantastic outcomes. Like they'll have 2 patients per operating room where they basically have 1 microscope. They take care of a patient. The patient on the next bed is getting prepped. They don't even change gloves. They basically take their gloves, dip them in like a chlorhexidine solution, move the microscope over to the next bed, do the surgery while somebody else is getting prepped on the other bed. And they're doing these, what they call manual small incision, which is essentially, I mean, it is an extra cap procedure. They're not doing phaco. They're getting these huge dense lenses out of the eye within 3 or 4 minutes. They're not suturing these huge incisions. They actually make all of their lenses in-house, so that they make all their own intraocular lenses. They make all of their own viscoelastics. And and these surgeons and the patients, I mean, they get amazing results and they take care of this huge population. And that's sort of one of the reasons, I mean, because most of these patients are not getting drops and they're not even getting a post-op week 1 visit. They'll get a post-op same day visit and then they sort of go on a bus back to their village. And then these patients just do great. So it's a really interesting case study and a completely new, different way of taking care of patients than we are, but doing an amazing job at it. It's a very neat place. So anyway, so maybe that's, I think Joel is back with us.
I am, and just, that was bizarre. All of a sudden I found myself talking to myself, which
All right, well, I will,
I just need to get my PowerPoint talking to me more. Completely. Are you folks seeing my presentation?
yeah, we can all see it. Yep.
Okay, because I lost my, there we go. So we'll continue onward. Sorry about that. Just all of a sudden I lost all my connection. Hopefully this storm isn't going to affect that. So moving right along, some of the most important concepts with the eyelid anatomy are the upper eyelid elevators. And we typically think of just the levator providing 12 to 16 millimeters of lift to the eyelid, and then the Mueller's muscle underneath in this area here will provide anywhere from 2 to 4 millimeters. 4 is pretty optimistic. It's usually going to be 1 to 3. A lot of people utilize their forehead muscles in order to help lift their eyelids more open. And so with the frontalis muscle, we can get easily 3 millimeters or more of lift. For patients who've had paralysis or a disinsertion of their superior rectus muscle for whatever reason, their lid will typically fall a couple of millimeters. So the superior rectus muscle with its attachments, fascial attachments to the underside of the levator, will also provide for some lift as well. Now, one of the most important things that I want people to get out of this presentation is that the normal levator function is 12 to 16 millimeters. That is a critical concept. So if you take away nothing else, that's got to be high on your list of priorities. So when it comes to severity of ptosis, you can have a normal eyelid position, you can have mild, moderate, or severe. And
Well, I think I might have frozen again.
unbelievable.
Okay, no, you're back on.
Okay. And then for patients who have moderate or severe, you can actually have, in addition to obstructed vision,
Yeah, in Joel's defense, I think there's something happening in Longmont with our power, because I'm seeing, even though my internet's not going out, I am seeing my lights blink on and off, and so I think there might be something going on with the power in Longmont, and maybe it's affecting his internet. Hey, Micah.
Yeah.
Will you call Joel and suggest that he have him try to use his because his cell phone is like a wire, turn on the wireless on, and have him connect his laptop to the cell phone and see if that'll avoid the internet issues.
Okay.
All right. Well, sorry for the blizzard gremlins. Let's see. We have a note that the power in Greeley is sort of fluctuating as well. So yeah, it's a little blustery outside. There any any questions or things that maybe you want to expand on in some of our earlier talks? Trying to think real quick. Let's see.
Yeah, I guess we can open to any glaucoma or retina related question.
I'll
Even
just
unrelated as well.
I skipped through a couple slides, so while we're waiting for Joel to come back on, I'll just I can go through some of those slides that I skipped, and then just sort of chime in when Joel's back on. So so I skipped through amiodarone a little bit. I talked about it in terms of the cornea, but interestingly, amiodarone can also cause an optic neuropathy. And one of the most challenging things about amiodarone and optic neuropathy is that it looks very similar to an ischemic optic neuropathy. And patients who are on amiodarone are already going to be already going to be cardiac patients, and they're already going to be in the high risk group for ischemic optic neuropathy. So it's a little challenging to differentiate those two because it really is quite different. Because if they have an ischemic optic neuropathy, then obviously there's no trouble with continuing the amiodarone. And, you know, versus if the amiodarone is really causing the optic neuropathy, then you would want the cardiologist to stop it. And it's really sort of amiodarone is more typically going to be bilateral and in sort of more of an insidious onset rather than the I woke up this morning and half of my visual field is missing. But both of them can cause disc swelling, so it can make it very difficult to differentiate the two. So I think this is sort of a really, and we actually had a challenging case of this come in about a week and a half ago, and sort of been hemming and hawing because the cardiologist really feels that the amiodarone is really helping the patient and really is important for their cardiac function. So it's a little bit of a challenging to figure out what the right thing to do. Joel, are you back on, or should
I'm here.
go over another slide for a minute while you're getting set up? Okay, there we go. Great.
Sorry about that. I'm now using my cell phone as a hotspot, so hopefully this will behave more so. All righty, so once again, I was talking to myself. Sorry about that, everyone. That's the nature of snowstorms and Zoom and so forth. Anyway, so critical things, just like for any problem, we want to do the history and then the evaluation. We want to know about duration, how long it's been there, symptoms, is it blocking their vision or not? Critical thing is there any eye irritation, sensitivity to light, double vision? Those are critical factors. And so the external exam, we want to know about the position of the eyebrows, the eyelids, such as this gentleman here, where his eyebrows and eyelids are falling into his eye sockets, and the position of the upper eyelid crease, which you can't even see in this gentleman, dermatochalasis, brow ptosis, are there any masses? And again, the critical thing here, harp on it, levator function. So margin to reflex distance, MRD1, is the distance between the pupillary reflex pointing straight at the person and primary gaze and the edge of the upper eyelid. And you can see in this patient here, it's about 0.5 to 1 millimeters. On the right side, on the left side, it's a good 3 to 3.5 millimeters or so. And for those who are really into it, MRD2 would be the distance from the pupillary reflex to the lower lid, but MRD1 is what we focus on. And then the important thing, another important parameter is the levator function, and that's the distance from the edge of the upper eyelid in extreme down gaze to the edge of the upper eyelid in extreme up gaze. And I'm showing this picture here on purpose because this shows a real common problem that occurs with evaluating patients, is that they very frequently are using their frontalis muscle, oftentimes just on one side, to compensate. And when we're doing this measurement, we need to put our hands on their forehead right above the eyebrow and block their use of the frontalis muscle so we can get an accurate measurement. So that's an important concept. And again, the average normal levator function for an adult is going to be 12 to 16 millimeters. So levator overaction, there are patients who, I don't want to get into it in some major way, but when you lift the droopy eyelid, the other eye upper eyelid on the other side will drop. That's related to Hering's law of equal innervation. And some people, in the process of trying to compensate for a droopy eyelid, they overlift with the opposite side, giving a retracted appearance. So like any ocular problem, we're going to do an eye exam. I don't have it listed here, vision. No one goes in or out of our office without having a vision measured. So that's should be on the top list of the list here. Pupils. And we want to know if there's an asymmetry, if there's irregularity, if it's constricted, dilated, motility, is there a strabismus, is there a problem with double vision, Bell's phenomenon. If you're not looking at the eye when it's in primary gaze, you're going to get an artificial measurement because it'll be swung upwards. Anterior segment, is there inflammation on the lids, the conjunctiva? Is there significant dryness, any keratitis, things of that nature? Pigmentary changes, extremely rare that that's going to be a contributing factor here. We'll talk about that more in a little bit. Possible ancillary tests, if we're looking at possibly doing surgery on someone, we want to know about their peripheral visual field testing, external photographs. Medicare made the wise decision a good 6 years or so to eliminate peripheral visual field testing for the purposes of determining whether they're going to cover it. They base it completely on photographs, which is a wide decision. There's so much variability in peripheral visual field testing. And it's just full of erroneous information. And we do have patients who are also trying to game the system where their eyes are nice. There's virtually no drooping of their lids, and somehow they just can't see anything centrally, and just creates a lot of extra chair time. Tears testing, we do want to know if people have significant dryness if we're contemplating doing surgery on them. So main classifications of blepharoptosis are congenital and acquired. And so congenital ptosis is a completely different animal, and it's due to a deficiency or an abnormal development of the muscle fibers of the levator muscle, as well as the tendon frequently. There's deficient contracture of the muscle and deficient elasticity and laxity. And again, I'm going to harp on it, decreased levator function. So it doesn't lift as well, it doesn't stretch as well. And that means that when we do surgery on these people with congenital ptosis, they will oftentimes have the inability to close their eyes completely. So there's the pro and con game that we play and have to explain to patients, parents, things like that. So congenital ptosis is associated with strabismus very frequently. There can oftentimes be an anisometropia and an amblyopia related to astigmatism or occlusion. And it's critical to do good cycloplegic refractions on these patients to do everything you can to provide for treatment of their amblyopia. And we don't call it occlusion amblyopia unless we've thoroughly treated the refractive errors. There are some congenital ptosis variations. They're very uncommon. I don't want to spend much time on. There's the blepharophamosis syndrome, where there's blepharoptosis and epicanthus inversus. There's also the Marcus gun jaw winking phenomena, and that was described back in the 1800s. Again, I don't want to spend a lot of time, but again, there's going to be a reduced levator function for the majority of these patients. It can be variable with Marcus gun jaw winking. Here's a kid with Marcus gun jaw winking, and when he uses his pterygoid muscle, moving his lower jaw side to side, his upper lid lifts upwards. And that's just due to an aberrant muscle nerve connection between the fifth cranial nerve and the seventh. So again, very rare and not something that any of us are going to see very frequently. And so again, we won't spend a lot of time. Blepharophamosis syndrome is responsible for 6% of congenital ptosis. There's a hereditary component to it. And again, we have the epicanthus inversus here, the blepharoptosis. and there are some other additional changes in their appearance. So more common type things that we need to be aware of are the main classifications for blepharoptosis. There's the neurogenic, myogenic, traumatic, mechanical, and pseudoblepharoptosis. So the neurogenic is going to include third nerve palsies, Horner syndromes, effects from botulinum toxin, typically going from the eyebrows, where it's injected, diffusing through the tissues into the upper eyelid, through the orbital septum, and getting into the levator muscle. Also, there can be patients with seventh nerve paralyses where they can have aberrant regeneration. We're in the process of trying to grow back the 5 branches of the facial nerve. You can have a misdirection in the regrowth where a nerve that was supposed to go to, say, the mouth area winds its way up, growing back into the eye area. And I'll have a slide on that here in a moment. So those can be an interesting variation. Third nerve paralysis, there can be congenital third nerves, but the things that we're going to be more concerned about are traumatic ischemic aneurysm, tumors, inflammatory changes. And so here we see a cartoon picture of a ptosis on the upper eyelid. The eyelid, because the fourth nerve is working still, the eye will be down and out, and the pupil will usually be dilated, but you can have an incomplete there as well. So it causes ptosis, but it's a completely different animal, which is usually obvious to all of us. Horner syndrome, that's an really important one for us to differentiate when you're considering possibly treating someone with apneic, because you don't want to miss a Horner syndrome. And again, described in the 1800s by Johann Friedrich Horner. And it's due to a lack of sympathetic innervation into the area of the eye socket where people can have ptosis. And in these situations, normal levator function, meiosis, small pupil, and inability to sweat in that distribution. Patients with congenital Horner syndromes will have a lighter colored eye. And so here we have a patient I saw recently with a Horner syndrome, a little bit smaller on the right side in conjunction with the blepharoptosis. These patients we do want to definitely identify because they can have a problem with a medical condition that really must be evaluated and worked up to make sure that they don't have a problem there. Over the years, I've seen patients with brain tumors, spinal tumors, patients who've had lung cancers, patients who've had dissecting carotid aneurysms or just an aneurysm of the carotid itself. So this is a very important one for people to make sure is not happening. Moving further along, botulinum toxin, as I said, there's the potential for Botox to diffuse from the brow area into the upper eyelid through the orbital septum. And anyone who does Botox can certainly have this occur. I've been doing Botox since 1992. I brought it to Boulder County in actually I started doing it in 1991. I brought it to Boulder County in 1992. And for those patients who do get a blepharoptosis associated with Botox, it lasts 3 to 4 weeks instead of the 3.5 to 4 months it works elsewhere. And that's why we never do Botox less than 3 to 4 weeks before the special event. Otherwise, you gotta do what you can. We do have another option in the past for patients who did have a blepharoptosis associated with Botox. We might have used abriquinidine, and Dr. Parikh and Rothstein, I believe, both touched on, actually, I guess Dr. Parikh, the allergic side effect potential that's higher with iopidine. So it's nice to have another option here with apneic. Anyway, going forward, I see a lot of patients who have blepharospasm or hemifacial spasm, or they have contraction of the orbicularis causing their eyelids to be closer together. Those patients are treated with botulinum to the orbicularis that will help open their eyelids better. And so that's a fantastic option for those patients. I touched on already the Bell's palsy with aberrant regeneration. And again, there's 5 branches of the facial nerve. And this shows here a patient of mine that I see regularly, actually a handful of patients who have this problem where she had a Bell's palsy on the right side. The muscles that were supposed to grow back to her lip when the seventh nerve tried to regrow, some of those nerves ended up here in the eyelid area. And so here, it's a little bit amusing here with COVID, and amusing actually not, but here she's actually pursing her lips, and you can see her eyelid closes almost completely. And so these patients will complain of difficulties keeping their eyes open when they're chewing, talking, and I have quite a number of patients I actually see where I do Botox injections to weaken the orbicularis so they can actually keep their eye open when they're talking and chewing. So moving along, because I've got a lot to cover here, I've been delayed a couple times. The myogenic and levator causes of ptosis are just involutional, where it stretches over time. It's oftentimes runs in family. It can be hereditary, and it can be it's due to a stretching or disinsertion of the levator. It can be due to contact lens wearing, people that I call champion eyeball rubbers, and post-surgical. There are some rarer forms that I periodically will see where patients who have chronic progressive external ophthalmoplegia, oculopharyngeal muscular dystrophy, or myasthenia gravis. So I'm speechless. I'm talking to the choir here. I'm preaching to the choir. One critical thing to be aware of looking for someone who's got blepharoptosis, I always flip their upper lids if they're contact lens wearers, because I've had quite a number of patients who've been to me for surgical consults, and I look and they've got major GPC, and number one, treat the GPC. And we all know that doesn't happen overnight, but I've had a number of patients where you get rid of the inflammation and the lid goes up. So levator dehiscence or disinsertion is the most common form of blepharoptosis. And you can see here, this is a typical patient with blepharoptosis related to dehiscence or stretching of the levator's insertion site from the tarsal plate. They have a high superior sulcus, and the lid crease will be higher than normal. The average Caucasian woman will have a lid crease at 10 to 12 millimeters. And this patient here, she's probably at 14 or more. And oftentimes patients will lose their lid crease because those little fascial fibers that go from the levator through the orbicularis to the underside of the skin, they just disappear. And as the levator slides superiorly, they lose that lid crease. So big questions are, why does this happen? So birthdays, that's the number one cause. People who have more birthdays are more likely to develop blepharoptosis, and the genetic predisposition. So those are the two most common causes for people to develop blepharoptosis associated with aging. But there are other causes as well. It can be unilateral or bilateral. And again, it's stretching or dehiscence of the aponeurosis. And the upper eyelid crease can be high or indistinct. They may have a deep superior sulcus like we saw with that patient just a little bit ago. And the critical thing here is they will have good levator function. The range of motion from all the way down to all the way up with your hand on their forehead just above the brow blocking the motion is going to be the 12 to 16 millimeters or so. So there we have that same patient again. Now we'll talk about contact lens wearers. I watch patients remove, put back in contacts not infrequently, and there are patients who use their hands and fingers like the jaws of life to get the contact lens in and out, especially some of Dr. Crohn's patients who have these large scleral lenses that are just large, and it takes a lot of effort to get them in and out. And you put contact lenses in and out of your eyes for 30, 40 years, manipulating them, a couple times a day, and you're going to cause stretching of the eyelid tendons. I tell people all the time, you rub, poke, pull, prod on your eyelids long enough, hard enough, you're eventually going to give me something I have to fix in an operating room. So I recommend people be as gentle as possible in the process of doing contacts as well as other maneuvers. So then we have the category of people where I call them champion eyeball rubbers. They are just constantly having their hands at their eyes and their eyelids. And for a lot of people, it's just a bad habit. Some people it's related to allergies. Some people, they will be utilizing a lid hygiene regimen that's more aggressive than they should be. There's the makeup removal. I showed you folks a picture of my wife a little bit ago, and she wore contacts for a good 35 years or so. And I watch her remove makeup once in a while, and sometimes it looks like it's a battle zone. It's a war zone. It's her against the makeup, and the poking, pulling, prodding has probably contributed towards that. And my wife in the background here is sticking her tongue out at me. So that's the reality, though. So my options that I give the champion eyeball rubbers, as I call them, the options I give them, especially if there's a significant other in the room, I recommend that they go get a cone from the veterinary supply store, or they go to an orthopedic office and get casts to put on both arms. It's just very impressive how people will manipulate their eyes. Back in the day, cataract operations took a good 45 minutes to an hour routinely, and the speculum was inside their lid for a long period of time. That, in conjunction with the traction suture that was routinely used through the superior rectus muscle, pulling the eyelid downwards, pulling the eye downwards, so that we could do surgeries up on the superior conjunctival surface. That combination would frequently cause the eyelid to stretch that's levator, and it's far less of an issue now that we're doing far shorter operations and we're not doing the large incision extra caps routinely here. There's another completely different animal, excuse me, called chronic progressive external ophthalmoplegia. It's genetic, and it will oftentimes start, frequently starts before age 30. And it's really a sad disease process. It's a bilateral progressive ptosis with, again, decreased levator functioning. Later on, there can be involvement of the extraocular muscles, where they basically, over time, will frequently have their eyes become pretty much frozen, where they don't move their eye at all. So they got a droopy eye, move their eye, and it's very unfortunate. They can get weakness of their proximal limbs. And there's a variant called the Kern-Serre syndrome of chronic progressive external ophthalmoplegia, where they can have retinitis pigmentosa. That's why in my earlier slide, I mentioned pigmentary changes, because it does occur in these patients. I've had 3 or 4 patients over the years in my care where I'm looking at them, I realize they have chronic progressive external ophthalmoplegia. I reach my hand over, check their pulse, and their pulse has been like 40. These patients will potentially develop heart block and end up needing pacemakers. And so these are important patients to identify. They're usually reasonably obvious. So there was another entity called oculopharyngeal muscular dystrophy. It's autosomal dominant of French-Canadian ancestry. And there's actually a handful of families here in Northern Colorado that have they will start later than the patients with chronic CTEO. Started with mild, and over time their levator function continues to decrease. Oftentimes they get blepharoptosis repair on them, only to discover 10, 15 years later that their levator function has decreased significantly, and they end up needing to have other types of surgery. One issue is for them have trouble swallowing, and when I see these patients, I always ask that question, and I'll refer them to a gastroenterologist. So the patient of mine who has oculopharyngeal muscular dystrophy had sling procedures where fascia or sutures are run through the upper eyelid, anchoring the eyelid to the eyebrow, so they can use their forehead muscles more so. She actually had her original surgery done elsewhere. She saw me recently and she needs the sling redone on the right side. Myasthenia gravis, another entity that will cause drooping eyelids. It's autoimmune. 40 to 50 patients present with double vision or ptosis. And that can be present in 96% of patients at some time. 10 to 20% of patients won't develop any other systemic weakness. We do blood testing for these patients, and they are generally managed by the neurologist who will treat them with medications such as mestinon or steroids or immune suppressants because of its autoimmune cause. For those who are old enough to remember JFK, his wife Jackie, who married Onassis, he gave notoriety to myasthenia gravis when he unfortunately developed it back in the late 60s and early 70s. Again, levator function, it can be decreased or variable in these patients. So again, if someone's got blepharoptosis and double vision, that's something that we always need to be thinking about as a possibility. So diagnosis for this, I don't want to spend too much time on it because it's rare and it's not really germane to the main topics here. So we'll pass through here on that. So traumatic ptosis. Traumatic ptosis can cause just swelling, pushing downwards, or they can actually contribute towards the disinsertion or detachment of the levator aponeurosis from the tarsal plate. I've had patients where they have lacerations that have gone right through it. It can be related to surgery. I've had patients who've had blepharoplasties elsewhere. Knock on wood, I've never had one occur, but I know a little more about eyelid anatomy than a lot of people. Anyway, I've had patients who've had blepharoplasties where the levator aponeurosis was damaged in the process of their blepharoplasty and developed blepharoptosis. It can occur from fracture or contusions as well. So there's a patient who had some recent trauma and the swelling is significant cause of downwards displacement, and just prolonged swelling can cause the levator to stretch. So mechanical causes of blepharoptosis are you can have a tumor, chronic swelling, you can have scar tissue that will push downwards. I've had patients who had orbital fractures of the orbital roof, between the orbital roof and the brain, where the bone of the orbital roof has infracture towards the levator, impinging it. And I've had to go in and elevate the bone upwards. Crossing my fingers, I wasn't going to create a neurosurgical problem, and decompressing the bone off of the levator muscle or tendon. Here's a patient with chronic swelling of her pushing downwards, contributing toward blepharoptosis. So mechanical and aponeurotic are oftentimes combined. Here's that gentleman we saw earlier. This is a very common type of patient I see routinely, where everything is just falling downwards. The eyebrows are falling into his sockets, the eyelid skin is falling into his sockets, and which came first, or the egg, was mechanical pushing downward, where the weight pushed down and created it, or always droopy. It doesn't matter so much because we're going to need to fix everything in this patient. Again, these are common patients I see where he needs a combination of a brow lift, a blepharoplasty, and a blepharoptosis repair so he can see anything. And these patients are usually extremely glad because their forehead fatigue and forehead in a minute, they can actually see more of the world. They're more bright-eyed and bushy-tailed. So pseudotosis, that occurs very quickly, where the weight from the eyelid or the brows is pushing downwards. It can be related to patients with deformities of their globe or trauma, things like that. But the most common form of pseudotosis by far is where, again, weight of the eyebrows, the upper eyelid skin is pushing downwards. Can you hear me?
Try turning off your video so that way it prioritizes the audio in the slide. See if that helps the connection a little bit.
Try turning off my video.
Like just stopping your video, and then hopefully it'll send the audio better.
I don't know that my video's on. Can you turn off my video?
Yeah, I can do that. So just go ahead.
Oh, wait, here we go.
Yeah, so that's good. So you should be able to just talk now, and I think it'll send better audio quality.
Oh, sorry about that. Interesting times. All right, so again, with pseudotusis, we take the weight of the eyebrows, the eyelids off of this gentleman's eyelids, and miraculously underneath, there are eyes that are nice and wide open. He does not have blepharoptosis. It's pseudotusis, where the weight pushing downwards, making it appear that way. So when it comes to doing treatment for patients who have blepharoptosis, there are non-surgical and surgical options. And again, with UPNEEQ, we have more better option now than we did previously. So surgical treatment, there are different approaches. There's the posterior approach, where we work on the conjunctival surface, and the anterior approaches where we work directly on the tendon, or sling procedures, which we do for congenital ptosis, CPEO, or oculopharyngeal muscular dystrophy. So we'll just briefly talk about those. This is a patient I did recently where I'm doing a muellerectomy, where there's a clamp on the underside of the upper eyelid that's been inverted, and we're clamping that. We run screws across underneath the clamp from side to side, and then we size this. I decided to make it too graphic. And that can provide for, unfortunately, a little bit more of a variable amount of lift. It's far from an exact science, but for someone who's got poor levator tendons, it's a reasonable option. So levator surgery in general, this is the most common form of
We have a question for you.
Yes, indeed.
So an audience question is, can you explain the difference between dermatochalasis and ptosis?
Wonderful. Let's go back to this patient here. This is my internet connection unstable suddenly. Anyway, go back to this patient here. Dermatochalasis is excess upper eyelid skin and tissues that are hanging down, and whether it's small, medium, or large, as far as whether it's cosmetic or it's actually obstructing vision potentially. So that's dermatochalasis. Blepharoptosis is where the upper eyelid is hanging down like a garage door in a lower position, blocking the vision itself. It all goes back to that margin to reflex distance, the distance between the light reflex in the middle and the edge of this upper eyelid. And again, for the average person, that distance should be a good 3.5 to 4, maybe 4.5 millimeters. And for someone with blepharoptosis, it's less. So if we look at the patient here, the margin is probably 0.5. We're probably at a good 3.5 millimeters. This is blepharoptosis versus the extra skin hanging down with dermatochalasis. So I hope that a little better. And like that gentleman I showed, this gentleman here, he has what I would call the triple whammy, where he's got a combination of blepharoptosis, dermatochalasis, and brow. You need to fix all of them. So treatment, talk about the muellerectomy. All oculofacial plastic surgery a love-hate relationship with blepharoptosis. And the reason is we're wanting a home run for everybody, get eyelids in the best position possible. But unfortunately, of all the things we routinely do, it's the least predictable. It's the least predictable. The average person drops about 1 millimeter from wherever you put the eyelid during surgery. Some people, average are average. Some people can drop more. Some people can drop less. And I tell patients that this is all about improvement, and unfortunately, it can't be about perfection. Because the average person drops about 1 millimeter, we purposely put it about 1 millimeter higher, and we cross our fingers that that patient has read the books, their eyelids have read the books and tables, and knows to drop the millimeter. And maybe they have, and maybe they haven't. So that's number one challenge there. Other challenges with blepharoptosis surgery is that when patients are sitting up and then they lie down, it looks different. It just, you don't have the gravity effects working against you or with you, and so it looks different lying down. Other things are these patients are having surgery where they have relaxing medications in their system, which decrease the muscle tone throughout their body. And so if they're using extra efforts when they're vertical and more awake, it looks different when they're lying down because of the relaxing medications. Also, they get sleepy and they just don't hold their eyes open as well. The moment you put numbing medication into the eyelid, just the volume of fluid pushes downwards and alters the appearance. The numbing medication is going to have effects on the orbicularis, decreasing the muscle tone of the orbicularis, so it's not closing quite as tight perhaps, and that's more apparent on a unilateral case where you're only injecting one side. The epinephrine in the numbing medication may possibly constrict Mueller's muscle, and that can alter the position. As you start doing surgery, just the trauma of the incision and manipulating tissue causes swelling that can push the eyelid down during surgery. And so there's all these factors that are ganging up on you that make it, again, of all the things we routine, predictable. And so when I'm walking into the room a week after surgery, I'm on pins and needles, hoping that we've, had real good success. And the reality is some people, they drop a little bit more, a little bit less. One thing that's really important that I harp on patients is to use cold compresses like crazy in the first 48 hours while they're awake. Tell them about swelling. If someone gets severe swelling, it will contribute towards stretching of the tendon. And so it was, 3 steps forward, 1 step backwards. The other thing is that when patients are using their cold compresses, we're telling them to use them like crazy for the first 48 hours. And, patients want to read their books, they want to watch television, and they want to, do it one eye at a time. And I beg them not to do that, because the moment you have one eye closed, one open, you are stretching the levator tendon on the side that you've got closed. So I tell patients when you're using the cold compresses, it's both sides or neither. It is never one at a time. We're just trying to maximize our results. So that's just a little editorial there on what the challenges of ptosis surgery. So here we have a patient, and again, one thing you can look at her, she's using her forehead muscle on that side. Here we are doing the surgery. I'm showing the pictures, not where the bleeding was happening, but here we've got her cleaned up, and I've made the incision through the skin, through the dissected through the orbicularis, exposing the superior 1/2 of the tarsal plate. That's the white shiny structure here. Next maneuver is to dissect superiorly through the orbital septum to expose the levator aponeurosis on that side. And then we use anchoring sutures to anchor the eyelid higher, better anchoring the levator to the tarsus. And again, we're looking for about a 1 millimeter overcorrection. And I had the nurse, this is a patient I just did on actually last Thursday, and I had the nurse take a picture, and they said, it looks like you got it nailed. And I looked up and I smiled, and I said, yes, but no, because you look here, and the patient asked her to open her eyes and look at the target. She's using her forehead muscle. So at the beginning, we talked about how the frontalis muscle can give up to a good 3 millimeters of lift. Well, I, don't show it here in the picture, but I using and her eyelid was too low, so I had to readjust it higher yet. So here she is in post-op, the goal being have the lid about 1 millimeter higher on the side compared to here, and I'll be seeing her next week and cross my fingers that we've hit the home run for her, because that's the goal. So that's the challenge of TOSA surgery. So non-surgical treatments, there's mechanical and there's medical. The mechanical forms of treatment are going to be taping the eyelid or using TOSA's crutches. So taping the eyelid, you two can go to Amazon or whatever, and you can get these eyelid tape maneuvers, things that will help with the eyelid higher. I don't personally have a lot of experience with them, but patients will use them. Crutches, the last time I prescribed TOSA's crutches was about 25 years ago. We don't do them here in this country. It requires an optician who's got a lot of experience. And again, 25 years ago, the optician I had was a guy who was in his 80s, I said, TOSA crutches, oh yeah, I've done those a lot in the past. And it was for a patient who was just not remotely a surgical candidate. And there are a lot of, yes, it can help, but there's a lot of cons with it as far as you have to stand pushing against the eyelids, lifting it, and then they have problems where they can't close their eyes and so forth, but it's a theoretic option. Medical treatment, aproclonidine, apodine has been utilized for patients short term. There can be allergy issues associated with that. And now we have Upneek. So let's talk about Upneek more specifically. We have to review the severity of the illness, be aware that it can only accomplish so much. Upneek is oxymetazoline hydrochloride. It's concentrated 0.1%. The concentration in nasal space is usually 0.05%, so it's twice that. It's applied one drop on the affected side. It takes about 15 to 30 minutes to work. It lifts anywhere from 1 to 3 millimeters. 4 millimeters would be really optimistic. I think it lasts about 12 hours. Important safety information. The bottom line is you can read through all this stuff later on. It's very safe. There are very few adverse side effects that go along with this. There can be some surface irritation, dryness, irritation for anybody. Conjunctival hyperemia was a very small report, nowhere near like what you see with some of the other alpha adrenergic agents. It comes in a vehicle hyperomos and kind of ampules, and it's been available forever over the counter. And the mechanism of action, again, it's going to stimulate the backside. And the nice thing about oxymetazoline is that it's got a 5-to-1 ratio affinity for the alpha-2 receptors versus the alpha-1. The pupillary muscle is almost entirely alpha-1, so that's why we don't see significant dilation associated with it. So, one of the questions is, well, do we need to be, it's always a good idea to check everyone for the narrow angle potential, but it's not a significant concern here. As far as improvement, I don't want to spend a lot of time on this, but in the protocols for getting FDA approval, there was a licensure peripheral visual field test result, as well as measurements on margin to reflex distance. And the graph is the left side, that's Upneek, and then this is placebo here, and this is the improvement showing that there was a definite measurable improvement in their peripheral vision. Same thing for the MRD, Upneek versus the placebo, and again, improvement in the MRD over time at 1 day, day 14. Upneek is in the green, placebo's in the purple, and for some, let's wrap it on 5 minutes. So this is a patient here who had Upneek used on both sides. It looks like it's worse on the left, but again, look, she's using her frontalis muscle on the right side, so lifting, she has a little bit more even lift than you might have expected, but she's not using her forehead muscle in the post-treatment picture here. It's maybe just a little bit higher there. Another patient treated on both sides. Right ptosis is worse than left, and both sides are improved. The right is lower than the left. Here's a patient who was treated on both sides, and I would argue that his lids are a little too high. He looks retracted. He looks where his eyes open a little bit too much. If it works for them, I wouldn't argue with that. Patients whose eyes are open a little bit wider certainly going to have for dryness and irritation. Also, if you look at these patients, the post-treatment pictures, the conjunctiva does appear more white. Again, for adverse effects, small percentage of patients having some surface irritation, dryness, very small, very well tolerated. We don't need to spend time on that. So it can be a significant improvement for patients on a daily basis or as desired. I get in trouble later on. She's a contact lens wearer and a makeup remover, and for her, it makes a very nice difference. For a special event, I think she might be inclined to use. This patient here is an apnea patient treated recently, and she has mild ptosis. She's young, she's only 35 years old. She wants to have something to help lift it. And for her, it's a nice option on perhaps maybe not a daily basis, but on a event. She's on Zoom meetings a lot. And for her, she feels like she looks tired. So maybe she does more. Actually using eyelid tape for many years. She had ptosis that was standing. And here she's used it on both sides. And you can see that the left side is, I'm sorry, we use it just on the left side here, and you can see that the eye is a little bit more white to this side. And then she tried it on the other side and lifted it maybe a little too high, but now if I look for someone like her, perhaps she uses Upneek on this side and Lumify on the right side. Just eyes look a little bit more even in coloration. So it comes in use preservative-free containers. There's about 4 drops in each one, but oftentimes one of the drops wants to sneak out easily onto your finger or the dropper, and that's used in the morning. Cost-wise, 1 month supply, 30 of them is going to be $105 for your patients, $225 for a 3-month supply, so $75 per month. It is only available through RVL Pharmaceuticals on a cosmetic basis. Insurance, they're not remote, they're not going through insurance at all. If someone has HSA or FSA funds that they want to use, they can certainly, make a case for utilizing that, but they're not going to even bother trying to run it through. For patients who you would prescribe it for them, the moment you hit send on the prescription to the pharmacy, RVL, they are totally on top of it. Those patients will be getting a phone call within about 20 minutes at the most. So they are looking for it to ramp up rapidly their distribution. Critical takeaways: don't prescribe it if they have decreased levator function, less than 12 millimeters, if they got unequal or unresponsive pupils, if they got double vision, or they surface disease treated first. So those are a lot of the main takeaways, and I appreciate your attention for not just me, but for all the doctors, and we really do appreciate your providing feedback on the talks today. Thank you.
So there was one question from the audience. So how long would you wait to do ptosis repair after a neurological event like a third nerve palsy or a stroke?
So patients with third nerve palsies or strokes usually have a whole lot of other issues going on in their world that need to be addressed. Treating the cause of the third nerve paralysis. And generally speaking, I would wait to see how well they have spontaneous resolution. You generally want to wait at least 6 months. One of the really frustrating things for patients with third nerve paralysis is that if they have significant persistence of blepharoptosis and double vision. If I lift their eyelid, I might make their awareness of their double vision all the worse. So surgery, strabismus surgery for those patients, depending upon what has recovered, can be very difficult. But in general, for TOSA surgery, you're going to want to wait